It can remain like that only there.
But what will be the harm if we pull it? You think there'll be bleeding from the disc?
Yeah, it is possible, but since it is a Terson syndrome VH, and in Terson syndrome usually peripapillary capillaries bleed. So disc and disc vessels usually remains normal.
Yeah.
So there is no harm in pulling that, but there is, I don't think is there any additional advantage of pulling that. So if it is not advantageous, then better we will not insult tissue.
Okay.
थोड़ा लाइट बढ़ाएंगे.
So now you are trimming inferiorly, or we are not able to actually see properly?
Yeah, inferiorly I have done.
Okay.
Just I am trimming temporally with
temporal. Okay. Yeah. Yeah, we can see the macula here.
Yeah. So in Terson syndrome, we had a plan to see periphery, and I don't find any peripheral lesion, so I am not going to do any additional procedure like endo laser and all that. PVD is also good and no treatable lesion, so I will do now FX.
And what about the peripheral dissection you have done? Or do you think you want to do a peripheral dissection also for a complete?
Sir, in such cases, I feel we can leave bases.
Because you have not put a belt buckle also, I think, because it's a case of trauma and a young patient.
Sir, but
so do you think, you know,
sir, actually in Terson syndrome there is no ocular trauma, sir.
Yeah.
So I feel that any unnecessary, we should avoid any procedure which is going to give us any additional benefit.
Okay.
So like just we are doing a core vitrectomy, we should go ahead with like that.
Okay, so you think that peripheral dissection is not essential in such cases?
Yes, sir. Yes.
Okay.
Even in such cases we can do partial FX and leave FX on. FX on.
Two months. I think color is okay, sir, because there is engorgement of
Hello. Boles, in case we pull that stump sometimes and there is bleeding, how do we control that? Like, what are your options?
Excuse me, sir, I could not get.
In case we pull that optic nerve at stump and there is bleeding, what do you do to control that? Like,
sir, like first of all, we raise our intraocular pressure. Even if that doesn't work, then we can do FX, or even if that doesn't work, then we can use PFCL. Even if that doesn't work, then at last option is that do FX and immediately put oil.
Yeah. And I think
oil or gas, we can put gas also, no?
Yes, sir, we can put gas also.
There are some people who do cautery over it, so I think
actually, sir, I feel cautery over disc we should avoid.
Yeah. So that's the message I wanted to send to the house, that we should never attempt a cautery over the optic nerve head, because that will cause deleterious effects.
Like in sometimes, like when we operate on CRAO patients, when we need to tug disc vessels very vigorously sometime, in that cases I have faced when sometime I had to use cautery. But in CRAO, since it is already a I mean very poor prognosis case, that we need to do sometime. Otherwise, in normal cases where we know prognosis, where we know result, so in those cases we should avoid cautery over disc or any major vessel. So effects done, patient case went very smoothly. We did not get any surprises.
Very nice, Boles, very well taken up, and it's good that this patient probably will get 6/6 vision, and so in retina nowadays we do get 6/6 vision, and cases like this they are pretty simple and doesn't cause much of a problem. Cases like Turson syndrome, you can just do what Boles has done, and probably just taken 15-20 minutes, not more than that. Thank you, Boles.
Yeah,
Very nice, Bolesh. Congratulations.
Thank you, sir.
Completing it very nicely. Yeah.
When we intervene such type of cases?
Yeah, since it's a case of trauma Turson's syndrome, there's there's hemorrhage in the brain also, there's vitreous hemorrhage. So once the condition of the patient stabilizes, and we see that the vitreous hemorrhage has not resolved over a period of 1 month, then I think there's no point in waiting. As you can see, the color of the blood has also changed so much, like from red it has become dark brown.
Ointment.
So it's not going to resolve on its own. So definitely, I think after waiting for 1 month, there's no point beyond waiting that. And once the systemic condition of the patient stabilizes, we can undergo, the patient can be taken up for surgery. As you have seen that it's a very simple vitrectomy which needs to be done. Only thing is, yeah, if there's an associated retinal detachment, then probably, and like Bolesh said, like in Turson syndrome, there is no ocular trauma as such. So the risk of retinal detachment itself is very low in such cases.
Yes.
Turson syndrome usually doesn't resolve on its own, so it needs to be taken up surgically.
Sir, regarding that stump bleeding, I want to add something. It's very important to know the blood pressure of the patient. Like sometimes we take the pressure to 60, it doesn't stop. Once the pressure is high, the marginal pressure is actually at the higher level. So you have to sometimes take it at 80 or 100. Many a times we have to take it up to 100 to control the bleeder. Also, I don't know what you
depends on the machine how much pressure can be raised.
And also
so
that
in Constellation, how much is it? Like
up to 120 we can
120.
Take. Yeah.
Okay.
And other thing is we can also put a direct pressure on that if it's not under control, even at 100.
So how do you give the direct pressure?
Just take the pressure to 100, and if the bleeding doesn't control, I mean oil and other things I consider very late.
And I think oil, we shouldn't put oil just to control the bleeding. I think if you just put gas, sometimes what we have seen that, in PDR cases or something, if there's a lot of bleeding, you can put in C3F8 gas and leave it for 2-3 days. The bleeding will be stopped, and you can retake up the patient after 2-3 days also, if the bleeding is too much.
Maybe my preference is while actually in PDR cases, even if
there
is bleeding.
If the bleeding is, not stopping.
Okay.
You can also leave PFCL and then come back, sir. You can also leave PFCL and then come back in few days. That also gives a very good result.
Yeah. Audio is not clear.
Increase the pressure 200, there might be the question of visibility. Increase the
audio is not clear. We will go there.
Up to 6 minutes, there are literatures on this. Up to 6 minutes, we can keep the pressure till 100, not 200. It's 200, sir. And we don't keep it continuously. We
Intermittently,
keep
you
60, 30, 60, 30. We keep on alternating.
The machine will also give you a beep, like after every 30 seconds. I think it gives 1 minute.
Constellation, it's 1 minute.
Okay.
Speaker. So any question?
So Bhulesh, I just wanted to ask you, since this was just a Terson syndrome, but if there was vitreous hemorrhage in vasculitis patient, so would you prefer putting a belt buckle in such cases in a young patient with vasculitis with just vitreous hemorrhage?
No, sir.
With some,
If in such cases, just I will add endo laser on area which is affected by vasculitis, and if I see any NV, then I will laser all those around areas. Just that is the additional procedure I usually do. I don't put belt buckle if retinal detachment or I feel it is if any tractional component is not there. I mean, belt buckle role in such cases is just to do base trimming without touching lens. I mean, it will give us just an extra edge. So, I don't think we need to do belt buckle in cases of vasculitis if RD is not there.
Okay.
I think Deepak sir, you want to...
For belt buckle, it's very important that we do a good BS scan preoperatively. Anything anterior to the muscle insertion, any traction or it's better to put a buckle. So the BS scan plays a very important role. And it's important that we preoperatively look for the any peripheral traction which is going beyond anterior to the muscle insertion. If it's there, it's better to put a belt buckle because it's very difficult in vasculitis cases to pull the very difficult.
And in so many cases, it happens like a simple vitreous hemorrhage, vitrectomy has been done, gas has been put, and for a month or two the patient will be fine. But after 4 to 5 months, there will be so much of traction that there will be a redetachment.
And many comes with that detachment.
Especially in young patients.
Yes,
so I preferably feel that putting a belt buckle in a young vasculitis always helps.
And sir, how do you decide when to inject anti-VEGF in these vasculitis VH cases in young patients?
See, if the patient has not been lasered any time and I see a lot of fibrous proliferation, I would prefer giving anti-VEGF and do it after 2 to 3 days. There's no harm in giving an anti-VEGF.
So you wait for 3 days?
Yeah. I wait for 3 days.
3 days.
3 days only.
And in diabetic VH cases, how long do you wait?
I think the second case is, sorry to interrupt, the second case is Dr. Ranjan Rai. So when OT is ready, we'll stop the discussion on vitreoretina's part and then we'll move on to phacoemulsification and anterior segment surgery. In the meanwhile, Dr. Please. So the second surgeon is dynamic Dr. Ranjan Kumar Rai, director of Patliputra Netradam Eye Hospital, and also MD from All India Institute of Medical Sciences, DNB, ex-assistant professor of RIU IGMS, senior consultant ophthalmologist, a dynamic surgeon, also director of Uddhav Balaji Eye Hospital at Siwan. Let's hear from him. Fortunately, he has now become very healthy after getting admitted to Medanta. So I think all the best, Dr. Ranjan.
Thank you, Dr. Vibhuti.
For coming out of that illness and then again deciding to come and do the live surgery is wonderful. So go ahead and all the best.
Thank you. Hi everyone, as Vibhuti said, I am Dr. Ranjan, and this case is of around nucleus grade 2-3 and बहन जी बत्ती को देखिए
So
बत्ती को देखिए.
The age of patient is 54, female. Yeah.
Patient is under anesthesia for half an hour before, so he sees little bit uncooperative.
So the left eye visual acuity is 1/60, K1, K2 is 43.58 at 63 degrees, and 43.90 is 153. So basically it is a spherical surface. So astigmatism is very minimal, 0.31 at 51 degree. Length is, axial length is 23.64 and IL is 21. So Dr. Ranjan Rai will be putting Clarion. The second eye is phakic in this case. So please go ahead, Dr. Ranjan.
I just put this phenocane because this patient is little bit uncooperative. She is under topical anesthesia. Incision planned in this case is at 105 degree. I am waiting for the phenocane to get its work done so that patient as well as surgeon can become more comfortable. So it is always better to give some extra time when the patient is under stress. This is for PG, this is not for expert surgeon who are sitting there. Keratome. And in the meantime, I am going to make this main incision. Give me some bud.
So usually how much time you give for trypan blue to work on the
30 seconds to 1 minute.
Okay.
So in the meantime, I used to make my main incision. As you can see, it's bleeding little bit, so it is nearly little bit limbal incision. The reason for bleeding is just to enhance the healing little bit faster after the surgery. So now main incision is complete. It is almost 3 planar incision. Saline, PSS. And I used to wash it with थोड़ा सा विस्को डालो कॉर्निया पर. This. So some water pooling is there. So all these factors should be taken into consideration during surgery for the beginners. These all small steps, but if you are not taking care of these small steps, this is going to create some visual problem for you during surgery. Now I am injecting HPMC, though it appears to be little bit high visc खोले हो, viscot high visc कुछ खोले हो क्या? So this is very beautiful microscope actually. First nick, waiting and looking up for this direction of the nick, and now inverting the flap, raising this flap, again waiting, looking for the proper direction. Here I thought the rhexis is going to be small, so I enlarge it little bit in the periphery, and now again continuing this rhexis. So by this way, my rhexis is now almost complete. So it is around 4.5 to nearly 5 millimeter rhexis. Hydro procedure is equally important. Before putting any further fluid inside the anterior chamber, you should decompress this and remove some viscoelastic. Just go inside, uplift the rhexis edge and do a gentle hydrodissection.
Ranjan sir, did you use any viscodispersive agent for rhexis?
No, it's HPMC.
Very beautiful rhexis you have made.
Yeah, it's a very beautiful rhexis, Dr. Ranjan sir. And you always take it anti-clockwise or a clockwise while you do the rhexis?
Right now what way I have done? Can you tell me? Is it anti-clockwise or clockwise? I have never noticed it.
It's anti-clockwise.
So,
what are the advantages of doing clockwise or anti-clockwise? Anyone?
so now,
I think it depends on the right or left-handed person.
Yes, sir. Of course, it depends. But in in anti-clockwise, sometimes there comes a blind spot.
chopper.
So
Yeah, do dialer de do.
it's always good to do the clockwise because when you come across the blind spot, you miss the axis.
So being lefty, I always do anti-clockwise. Let's be fair about it.
Most of us doing anti-clockwise. Yes.
Always
Anti-clockwise, yes.
prefer to rotate the nucleus with the two instruments just to reduce the stress over the zonules. So now this rotation part is complete. Now I need viscot. At this stage, I am injecting viscot and I am HPMC, डबल सेल टेक्निक। बहन जी बत्ती को देखिए, कोई दर्द हो रहा है क्या आपको? सुन रही हैं? दर्द हो रहा है? नहीं ना, तो आधा ऑपरेशन तो हो गया।
So what Ranjan sir just did is he just coated the endothelium with the viscodispersive agent and then he has put the normal HPMC. So this is also a preferred technique in such cases.
So I think in this case, few weeks back we had a great surgeon from Odisha. He did Phaco without Phaco. He was very excellent surgeon, but I don't think that clean karo cornea ko. IOP घटा दो तो IOP 50 कर दो।
So what is the guide for control of IOP, Dr. Ranjan? Please complete your job, then we can discuss.
As I have gone inside, the AC has suddenly become more deepened.
Okay, so you reduce the IOP.
IOP, हाँ. So what I have done, you can see the parameters. For this kind of cataract, this is my parameters for chopping. Is it focused?
Yeah, it's focused.
Okay.
Don't worry. Please go ahead. Beautifully divided into two parts, and now you are trying to hold for third chop. Yeah, so now it is nearly 3 parts.
This is the step where you should be careful. माइक्रोस्कोप फोकस नहीं है जी थोड़ा सा।
So there is a little bit of lateral separation you also do at the end of the end of. So
it's kind of mixed chopping technique. Neither it is pure horizontal nor it is pure vertical.
But the main aim is to crack it completely to the last fibers, and that is most important thing.
Viscot though. This is the step where you should be careful. Viscot. Now you are going to be in the rough sea. You are going to damage endothelium after this stage. So it is always better to coat the endothelium again. Quadrant. So I am taking some time to look at my rexes to the chopped pieces whether they are separated or not, and now you can see this beveled end sideways. This is just going to provide me more surface area for this emulsifying this nuclear fragment. And though people used to say inside the bag, but most of the Phaco procedure are at the iris plane level. And see this this my left hand is just supporting the nuclear fragment to stop this inadvertent movement and turbulence. This last piece, again, I need some HPMC or viscot kind of thing. Region is 2. This is going to give.
Dr. Ranjan, once you turn the Phaco probe, you will see that the first point of exit of irrigation is pointing towards the endothelium.
Yeah.
So while you have more space in, you're getting a good hold, will that exit point of irrigation not hurt the endothelium?
Yeah, that's very true, sir. That's very true, but doing this, this is already a bevel tip. So like this, I am at the parallel to this iris plane or rexis margin plane. While doing this, this angle is going more towards in this posterior capsule. So at the last piece, if there is sudden surge due to any reason, chance of hitting the PC is more, sir. This is my personal, I may be wrong. I may be wrong. I may be wrong, sir, but some habits used to be since very initial teaching.
So the flow rate is 38, and that's why there was wonderfully completed this Phaco emulsification. I think that point need to be taken into consideration, that the flow should be on the side, so that the actual convection currents are bringing the nucleus chunk towards the tip rather than there was taking it somewhere else. But with these machines and the way you coated the endothelium to be taken in between also, the flow should that is going to give added kind of support system. Actual convection currents are bringing the nucleus chunk towards the tip rather than taking it somewhere else. Irrigation, but with these two side machines and the way you coated the endothelium in between also, that is going to give added kind of support system. However, the point was well taken that
I just observed that Ranjan sir, before coming out of the AC,
irrigation port should have been on the two sides.
Maintained the AC with the viscoelastic and then came out of the AC. So this is very important step, especially in cases of where you get compromised PC. I just observed that Ranjan sir, before coming out of the AC, he just maintained the AC with the viscoelastic and then came out of the AC. So this is very important step, especially in cases of where you get compromised PC, like
cortex, cortex.
It's very important to come out after maintaining the AC and don't just suddenly come out.
Cortex.
A lot of surgeons have moved on to hydroimplantation to maintain the less and less viscoelastic.
Cortex, cortex.
So what do you do is what I was discussing with Subhash sir last time. If you are trying to do hydroimplantation, come out chamber to collapse. You again have to put viscoelastic to maintain the anterior chamber, then the whole purpose is defeated. So what do you do at that point of time?
Are you asking in cases of compromised PC or normal cases?
Routine cases. Routine cases, you want to use as less viscoelastic as possible.
Are you asking in
but
cases
at the
of
same time,
compromised
you don't
PC
want
or
the
normal
anterior
cases?
chamber to
Routine
collapse.
cases.
Routine
Each
cases,
time you are coming
you
out.
want to use as
So
less
it's always good
viscoelastic
to
as
do
possible.
the stromal hydration before
Correct.
entering into
But
the
at the same
anterior
time, you
chamber.
don't want the anterior chamber to
And,
collapse each
and
time you are coming
another
out.
advantage of coming
So
while you come out from the anterior
Correct.
chamber into the
Yes.
so sir has
Yes.
put the viscoelastics, and so one is
Yes.
to prevent another advantage of coming while you come out from the anterior chamber. So sir has stable anterior chamber, so one is to prevent the PC, and second is inadvertent PVD or long even later is unstable anterior chamber, so that it will prevent the inadvertent PVD or long even in later stage the PVD occurs.
Table, and surgeons have complained that suddenly the glow has disappeared and there is some vitreous hemorrhage. Surgeons have complained that suddenly the glow has that is why we don't want the anterior chamber to fluctuate. So probably that is why we don't want the anterior chamber to fluctuate. So we should do stromal hydration when we come out. That we should do stromal hydration when we come out.
Like hydro implant, if you are doing any kind of a hydro, you do like hydro implant, if you do the hydro, even in a toric eye, if you do the hydro entering into the anterior chamber, your AC will remain relatively stable.
Will it not cause? But will it not cause like stromal hydration? Will it not cause any improvements in the visibility?
No, you don't do a lot. Even stromal hydration, if you do the only along the incision, it will not impair the visibility.
I think stromal hydration in surgery is needed only if you have got leaky side port or the main port. If your ports are well formed at the beginning of surgery, you can just during the surgery that what is happening to the anterior chamber. There is a tendency sallowing regularly. Is it maintaining level of depth coming out of that anterior chamber? That is the pointer making hydration or no hydration or putting something.
Normally it's almost well formed, but sometimes we do get leaky, and we need to do maneuvers like this. Deepak sir, have you
when you take the out, anyway you are out, anyway you are position 1, that is irrigation. So your anterior chamber is already filled with BSS. So you are saying that stromal hydration with one hand and then you come out.
So some cortical fiber remnants are sticking to this capsular edge and posterior capsule. So I'm implanting the lens. Then after I will try to remove it. And lens I am implanting is 21.5 diopter Clarion platform. As the company claims that it is having minimal PCO, almost 99% it is PCO free, glistening free, and added advantage is it is going to give this 66 centimeter of this functional near vision, and I am going to inject the wound assisted, but इसको रख लो केराटोम दो, but my thought is keratome. Better to little bit in this 2.2 region, better not to rack this main wound. So make your insertion little bit more while you are inject under the BSS.
So you're putting it under BSS.
Under BSS. And I always enlarge this little bit of this my main incision. Now it is easily accommodating the. And this is my limit. You can see this IOL coming beautifully, and it is very smooth. It is very almost without any pressure. It is directly going inside the bag. So this is the way how one should consider the IOL implantation under बहन जी तीन बत्ती दिख रहा है कैसा बत्ती दिख रहा है तीन
Good morning, Dr. Ranjan.
Good morning.
So, what I was telling that you are advocating for increasing the incision a little bit, na?
Little bit, yeah.
So, what advantages do you get doing this?
बहन जी 3 बत्ती देखिए. Advantages, sir. When your incision is tight, this cartridge is going to fit very snugly, and you have to exert little bit extra pressure. Under water, to get the better control, it is better to go with the, not with the exactly 2.2, you can go by 2.3 or 2.4 to make your, बहन जी बत्ती को देखिए, cortex. Now it is safer for me to remove this cortical remnant. These parts. बहन जी बत्ती को देखिए. So I think now patient is becoming little bit more impatient, and I too. So I think the visual axis is clear, central 5.5 millimeter of this optical zone is clear. So few cortical fibers are there, I can leave it. I don't think it is going to do any visual hampering in the future. Thank you, sir. Thank you for patience watching. Any question, most welcome.
No, first of all, let me congratulate you. Batted like Rahul Dravid, stayed on the pitch for long duration to show the nuance of or the finer steps also. So wonderful demonstration of a skill and technique also. Big congratulations to you, and I must say everyone also clap for Dr. Bholesh Ratna. He did a wonderful vitrectomy and we forget to clap for him. So for this clap was for Dr. Bholesh and Dr. Ranjan.
Yes, sir.
Yeah, once you have completed, then we will bombard with you few questions.
Most welcome.
But wonderful demonstration of technique.
बत्ती देखिए बहन जी, जोर नहीं लगाइए.
Beautiful rexis which is covering the IOL very well.
Patient is now straining, so this. How many of you are going to give this tablet acetazolamide before phaco surgery?
Question we have to ask.
No, not antibiotic. I always give this tablet acetazolamide 2 tab 1 hour, 1.5 hour before the surgery.
So let be very fair. If patient is myopic, usually I avoid giving any kind of acetazolamide or some kind of medication to reduce the IOP and shrunken the vitreous body. But in cases of hypermetropic eye, shallow AC, usually we give. It's not a very routine kind of prescription, but yes, we have to judge that. So you were operating on number 1, Luxor Rivalia.
Yeah.
So I'll ask the advantages, what you felt here, number 1. But let me congratulate you again on one more thing, that your control of hands was excellent, because the way you were putting this viscodispersive device inside the eye when changing the hands, it was wonderful.
Yeah, so I am so proud to be standing next to Dr. Ranjan. He had done so well despite not keeping very well for last few days. So big thank you to Ranjan.
Thank you, sir.
Demonstrating a skillful surgery. So now whatever question you want, you can have him for another few minutes till the time this patient is prepared.
So what advantage you felt was there on this microscope? You are operating on another microscope at your own place.
चश्मा दे दो मेरा ना चश्मा.
Sir, when Ramamurthy sir is ready,
yes,
just let us know so that we can learn little bit.
See, this microscope is really good. The depth is better compared to other microscope available in the market. The red glow is fantastic. Though even the patients were moving up and down, patients was a little bit less cooperative, but throughout the surgery I am able to operate under the red glow. This is one thing, and depth, I can see the 4 micron thickness of posterior capsule throughout the surgery and 8 micron thickness of Bowman's Desmond complex throughout the surgery. I mean to say the depth is really good and red glow is good. Handling microscope is also easy in the microscope itself. You can put this up and down. You can do macro focus as well as micro focus. So these are the advantages. Now you can ask what is the disadvantage. Hello?
Yeah, go ahead.
So just I talked to the company people. Disadvantage is it is not for the beginners because of this cost factor. This is very true and reality. Though company people are standing beside me, they are raising their eyebrows. But this is one disadvantage. Otherwise, whole technical part is fantastic.
Can we focus the camera on the surgeon, please?
Hello?
We want to see you while you are talking. Now we see you.
Go ahead. You can ask.
So you were talking about the disadvantages. Is cost the only thing? Is cost the only deterrent factor for beginners, or is there some learning curve in this particular microscope, or it's as usual?
See, my personal opinion, I have gone in this field. I have spent almost 20 years of working as an independent surgeon. My suggestion for beginner also is always start with the good quality microscope, and you can use this average grade of Phaco machine in the beginning. This is my personal opinion. Never compromise with the microscope quality. This is my perception. Now for me, as we are growing older, the contrast, visual acuity, everything is declining with the age. So for our age, this quality of microscope is mandatory. This is my again, I'm not biased with the company people.
So I think the best advantage in this microscope is that with the lowest illumination, the lowest macular toxicity, you can still have maximum depth perception. You can have the maximum red glow with the minimal macular toxicity. So that is the biggest advantage of this microscope as compared to other microscopes.
Yeah, absolutely correct, Dr. Satyajit.
Thank you very much. Is the other case ready? One minute.
Thank you.
Dr. Ranjan.
Yes, please.
In your case, you made the dye to stay for a longer duration.
Sir.
This I am asking because in any case, in your experience, you found that endothelium is being stained for when kept for longer duration.
What book says you can keep dye from 30 seconds to 2 minutes. This is what the book says.
Just a second. We are going to start the most awaited case right now. So we'll just give 2 minutes to questions and to answer from this gentleman and the great surgeon Ranjan Rai ji, and then we'll move for the introduction for Dr. D. Ramamurthy sir and the case description for the next case. Okay? Yeah. Go on.
Yes, Satyajit.
Yeah, so one of the things which I was noticing is in the last stage, when especially that is more prone to having a posterior capsule rupture, in your left hand when you were holding the chopper.
Yeah.
Yeah, so that is the time when I turned the chopper towards 90 degree and not keep it facing towards the posterior capsule when we are dealing with the last pieces, because when you're doing on Centurion it doesn't matter, but when you're doing on other lower end machines, there's a fear of surge, and that is the point where you can hurt the posterior capsule. So I always turn the chopper 90 degrees so that even if it hurts the posterior capsule, it doesn't tear it. So what are your thoughts on that? Would you want to use a spatula in the end or something to be more careful? Subhash sir, we can't hear you.
Yeah.
Hello, can you hear? Yeah.
Yes.
Since the second case is almost ready, so we want the introduction slide of Dr. G. Ramamurthy. I know that sir doesn't need any introduction, but for those who are newcomers, they must know and they must emulate the great person, the great surgeon. He is internationally known. So let us have his introductory slide, and then the case description will be read by Sonali from here, and then we'll move ahead with the another case. We can have a lot of discussion. Don't worry, we are going to have full day. Okay.
I think one of the biggest achievements of Ramamurthy sir, out of the whole distinguished career that he has had, is now that Eye Foundation is shortly going to go public. So they have made so many centers throughout South India, and his son is working so hard in expanding, and sir himself, that it's already going to be in the public listing in a year's time. Eye Foundation, Coimbatore. Ramamurthy sir, already the audience is talking about investing in your company now.
Hello.
Yes, please go ahead.
Very good morning, everyone, and thank you so much for this kind invitation to be a part of this meeting. It's always a pleasure to be back in Patna, and the last thing I want to be told about me is what you just now said, Satyajit. I mean, I'm myself not sure about what's going to happen. There is talk about it, but let's see.
That's a big achievement, sir. 10 years back, you had done a live surgery in Bhagalpur, if you remember.
Yes,
that
yes,
was
yes.
such a treat to see you.
So shall I share the details of the patient?
Yes, please, go ahead.
So it's a 57-year-old female, and she came to us with a diminution of vision since last 3 years. On examination, the visual acuity of the patient was hand movement, and the anterior segment finding was normal, but she had a mature senile cataract. Fundus was normal in this patient. Her steeper axis is 46.53 at 4 degree, and the flatter axis is 44.27 at 94. Her astigmatism was around plus 2.26 at 4 degrees, axial length 23.34, and hence the patient was planned for a trifocal toric lens, panoptic toric T6 series, and the incision is planned at 3 degrees. Over to sir, the fellow eye of the patient is phakic.
ठीक है. What's the AC depth? Very good morning, everyone. Can you hear me?
Yes, sir.
Excellent. I am going to be operating on this very nice lady. She's around 60 years of age. She has a significant total cataract with a significant astigmatism. The plan is to place a panoptic toric intraocular lens. I'm using the Rivalia operating microscope. I have wonderful experience with that. And also the Centurion with the active Sentry overlay. And I'll be implanting a panoptic toric. And she has a significant amount of astigmatism. So we are going to be using a T6 intraocular lens. I like to bend my own microrhexis, and I expect this to be an intumescent cataract because the AC depth was just 2.6 millimeter. I didn't see the patient on the slit lamp, but I think it should be, maybe saline jara par dekhiye. Can I have the side port? Maji jara सीधा light पे देखिए, light देखिए, सीधा ऊपर देखिए. I like to have my side ports at around 70 degrees from my central port. Light देखिए, and this is the 1 millimeter side ports. Parakin hai. And I always inject because I'm doing under topical and the lady is not too comfortable. I'm going to even otherwise routinely I inject a little bit of parakin. Seedha light dekhiye. Maybe this is one of the few instances where a peribulbar or a anesthesia may be indicated because it's a live surgery and the lady is a little apprehensive with a total cataract. And let's see how we manage. And now I'm going to be injecting a Trypan blue. Obviously this case requires staining. And I always inject, add to that I think. Normally in my place what I do is to make the side port incisions and then make the main port and then inject this Trypan blue and air bubble main port 2.4. Ye wala. So that gives me some time for the dye to be in contact with the anterior capsule, and as you saw in the earlier case, get a beautiful staining of the capsule. And I have shifted, I was using 2.2 millimeters for quite some decades. But as was discussed earlier also, now I have shifted over to 2.4 millimeter saline. This saline. The simple reason being that it has been shown that the, see the light pe dekhiye, astigmatism induced by a temporal clear corneal well-made 2.4 millimeter incision is just the same as what is induced by a 2.2 millimeter incision. And when I have a 2.4 millimeter incision, I find that I have a excellent, there is no stretching of the wound, there is no damage to the wound, side port, Sinsky hook. There is, whether during the introduction of the intraocular lenses or whether introduction of the Phaco probe, get a very clear entry. And if the final size of the wound remains the same as what you started out with, that has the best stigmatic impact. I have kept it at 5.8 millimeter because my idea is to run the rhexis within this. I've used disco whisk, and that with the combination of the sodium hyaluronate tends to flatten out the anterior chamber. And the idea is that 5.8 millimeter, I want a 5.5 millimeter rhexis. But I'm going to try to run this within the confines of this Barion digital overlay that we have. As you can see, it's quite an intumescent cataract for 2 ml syringe, saline ke saath. So you can see that fluffy material coming out in spite of the high molecular weight viscoelastic. So I'm going to remove that.
Sir, in these kind of cataracts where there is also a fear of it being intumescent and the rhexis running away, would you not want to just do it with the side port rather than making a main incision which is wider? There will be more viscoelastic leakage, and then just doing it with a small side port, completing the rhexis and then making the main port?
No, excellent point, Satyajit. But as you can see, I'm not using the main port for making my rexus at all. My rexus is entirely made through the side port. I'm stabilizing through one side port with a Sinski hook because the patient is a topical and moving the eye quite a bit. And I'm going through the side port. Microrexis forceps. So there is a tendency for it to run off.
So this is a very important take-home message. One must realize when you have to shift from a cystotome to a Uttarata forceps. Even with a very, very experienced surgeon like Sir himself, he has decided to move to Uttarata, and that is the best thing to be doing.
I'm using a microrexis forceps, and I'm actually much more comfortable with a 26 gauge needle. But as Satyajit is pointing out, whenever there is a challenging situation and there is a tendency for the rexis to run off, it's a good idea to shift to. And as was also emphasized, there is no distortion of the main incision, and because of which the chamber tends to remain formed. I'm not quite happy with the way it's proceeding. Let's see. No, we have to do something. Yeah. Can I have the rexis scissors? Microrexis scissors. सीधा देखिए अम्मा जी, सीधा देखिए. Saline in the cornea. Little visco. Light देखिए.
This is real-time learning for all of us, and challenging situations can happen with anybody at any point of time, but how best you manage it and how best the experienced surgeons manage it is something we are seeing in real time, which is a good thing for us to take home.
Somehow not able to get a hold on that. 26 gauge needle. 26 gauge needle bit. These are excellent instruments, but not something I brought, so I'm not somehow comfortable with it. Let me see whether I can proceed with the. Spending a lot of time on rexis, I know, but I mean it's time well spent.
True.
26 gauge needle. No, I use all these instruments interchangeably. It might look like a very novice surgeon operating, but I think.
No.
bend over the 5cc syringe, saline.
So you still wouldn't want to use the main port for the Utrata forceps, sir?
No, I'm not using the, except for the, I'm using, never using the main incision for the Utrata forceps. I'm always going through the side port. I'm seated temporarily, 26 age. सीधा लाइट देखिए, उठाटा, नहीं ये सीजर्स है, मुझे ये चाहिए. Wow, that was one of the longest exercises I've ever made.
Wonderful, wonderful, very nice.
It's still a little smaller than what I would have wanted. In these kind of total cataracts, hydrodissection is not necessary at all. As you can see here, I'm able to rotate the
very important take-home message. Very important.
Biscuit. Okay, let's have the Phaco chopper. Now I'm going to be initially evacuating the cortical material. I use only longitudinal Phaco initially and then shift on to just torsional. So I have my Phaco chop settings initially. That's essentially because I want the irrigation parameters.
What is this, grade 5 cataract?
It's a white cataract with a fairly brown core.
Yeah.
And it was an intumescent also, that's why all the bulging and
correct.
And the chamber was just about 2.6 millimeter. Can I have a sculpt?
Such a treat to see you operating.
Chop. I usually use an intraocular pressure of 30 only, which is a bottle height of 41. But I find the globe is too soft. Can you just increase it to 50?
Sir, can we focus a little bit, sir?
Is it okay?
Perfect. So this is a direct chop.
This is a classical multi-level chopping. It's a very dense nucleus, and as you can see, I had to go at different levels.
Sir, in these kind of intumescent hypermature cataracts, even the zonules are a little compromised.
Absolutely.
So we have to be.
And I want that complete red glow. That tells me that the lens is completely divided. So all along I'm using only longitudinal Phaco with the IP with the IP off, because I find that when you core the nucleus, we could discuss this later.
Can we center it a little bit?
Better?
Now, yes. Thank you.
you can see very little parameters used for even the dense cataract like this. It is not just the phaco power, but even the
hold,
aspiration, irrigation, the bottle height, everything. I am quite happy with these 4 quadrants of viscoat, and I need some HPMC. Now I am going to do the quadrant evacuation. I use the dispersive viscoelastic to nicely coat the endothelium, and I am going to be using HPMC in the center, because viscoat is something which is thermogenic, and sometimes it clogs the port and causes a wound burn. So I always like to operate in a lake of HPMC. This is some kind of a modified soft shell technique, quadrant remol. I am keeping it angulated posteriorly and keeping it as posteriorly as possible.
You have made such a nice division of all the 4 quadrants, but from 10 years earlier, I remember you had given advice to everybody that if you don't see the red glow at the back, use 2 dialers or 2 spatulas to separate it. You can come out, separate it, make 4 quadrants properly, see the red glow, and then advance towards phacoemulsification.
Absolutely, Satyajit. I'm so happy that you remember this. I mean, I'm sure you're doing it yourself. In the sense that, supposing this chop had not come through, that's the reason I make this trench. Sometimes extremely hard brown cataracts, whatever be your expertise or confidence, you are not able to get the Phaco Pro or the complete division. I do not hesitate to just, I'm going to fill up again with viscoat, because it's a fairly hard cataract. I'm using fair amount of power. I want viscoat enough.
That's such an important message to protect the endothelium again and again and again, and the posterior capsule.
HPMC. And I would have just extended that central trench to make a complete division and use a 2 side port incisions, the Sinski hooks, to essentially divide the nucleus. So basically, you should not provide with quadrant evacuation unless you have broken the backbone of the nucleus, and that's whenever you try doing that, then the whole surgery becomes a little messy. Oh my God. Oh, I have a PC rent. Oh. Hell. Can I have the vitrectomy? I don't know. This is not my day. I mean, vitrectomy. I don't know if in this. We have a problem. I think I'll have to shift my lens also. And I'm sorry about this. I don't know where. Everything seemed to be proceeding very smoothly.
You have done very nicely, sir. There's no problem.
There is a nucleus fragment inside also. But I'm going to go ahead and deal with the anterior segment. We can have Ramstone estate also.
Dr. Sonali,
yes, sir.
Can you brief us also on the next case of what is?
No, let's finish this case. I would definitely like to show this in the sense that, this is not going well, but it's important that you see cases which we don't go well also.
Yes, sir. Yes, sir.
Can you identify a 3-piece lens which can go in? Fortunately, the patient doesn't have a, I need tramstone state also. Fortunately, the patient is phakic in the other eye, and I'm aware of the fact that there is a small nucleus fragment that has gone in, but I'm going to still, I think there are competent vitreoretinal surgeons available here. So I'm going to go ahead and implant a lens, and I didn't see any surge or anything. I don't know how this...
Very surprising, very surprising. I didn't see any time the posterior capsule coming up.
If these particles are there, it's always a good idea to do a 23 gauge, 25 gauge vitrectomy or a 27 gauge vitrectomy to remove these, and because otherwise the patient is disturbed by these floating particles for quite some time. Can I have aspiration? Aspiration. दोनों में irrigation aspiration लगा दीजिए. Sorry about shifting the entire scenario, but let's see what we can learn from this. Please. Got it. Now going to deal with the cortex.
Sir, would you want to put a IUL at the...
Sorry?
Would you want to put a IUL like we do in an IUL scaffold kind of a thing when situations like this happen?
Yeah, I'm going to do IUL scaffold only. No, it also depends on where you are operating. For example, I am confident that we have good vitreoretinal surgeons here.
True.
So there is a small nucleus fragment which has gone in. I'm sure that needs to be addressed. And normally, we would even shift the patient to the adjacent theatre where the vitreoretinal surgeon is operating and have that removed. But this can be done in the post-operative 1 week or so also.
It was a very, very small piece which went down. Very small piece. Yeah.
सीधा देखिए. हाँ, ट्राई कर चाहिए. You can see those vitreous strands still there. So never a good idea to drag on those. Vitrectomy. Vitrectomy, yeah. Try कर दीजिए. Yeah. सीधा लाइट देखिए. डाइल्यूट किया. Ideally it should be ठीक है. अभी vitrectomy दे दीजिए. Ideally it should be at least 1 in 3 dilution or 1 in 5 dilution. It seems to be. You came to see something else and you're seeing something else, but please feel free to ask questions.
Sir,
or
what
give
we are
inputs.
seeing is also very, very important, sir. It can happen with any one of us, sir. It's very important to see how you deal with it, and we'll have so much to learn from you.
सीधा लाइट देखिए माँ जी. It's always a good idea to confirm using tramstone estate that the entire vitreous strands are completely removed. I always like to do that before creating a optic capture. Three-piece lens liya na apne? You have taken a three-piece lens. Yeah, please load it. Whatever. Yeah, I mean, normally what you give for a. Yeah. So we'll enlarge the incision to 2.8 or 2.8 knife le lijiye.
Sir, sometimes this tramstone goes into the posterior cavity also.
Yeah.
So
Sometimes not invariably it will go in, but I mean it's okay because it's going to only reduce the inflammation. It's a very transient raise in intraocular pressure, sometimes it causes. That's not really an area of concern. But normally I use, thankfully it's not very often that we have to use it, visco, just visco, normal visco. It's diluted tramstone estate that is used. In this case I thought it was not. See the light dekhiye Maji? I am filling the visco in the, this is HPMC, in the sulcus, in front of the capsular bag, because that's what I want to implant, where I want to implant the lens.
Sir, this HPMC will also have a tendency of going in the vitreous cavity, sir?
Yeah, we will remove it before creating an optic capture. You are right. Yeah, 2.8.
This looks like an absolutely wonderful surgery, sir.
That's nice of you to say that, Satyajit.
No, it's very nice, sir.
See the light dekhiye. Because the initial incision was 2.4, I'm just enlarging the incision. Nahi, ye lens. See the फिर load कर दिया lens. This thing was not large enough. Visco. Glove is also very hypotonic, so because of that, knife दीजिए.
I think in these kind of cases, even the microscope plays a big role. The Luxor microscope, you can see everything so clearly with such a wonderful depth perception that it eventually the management even becomes easier.
So that's absolutely true. You know, it has almost 6 times the red glow of a regular microscope. So even as you can see, even the lady is moving her eyes, you still have a very good red glow, and Depth of focus is also very good, so that you can see the cornea, you can see the incisions, you can see the capsulorhexis margin, and the viscoelastic in the vitreous cavity.
Yes, we can see that also. Sitting here, we can see it so clearly. You must be seeing it even more clearly.
So I'm just waiting for the lens to be loaded. Basically, there have been occasions when faced with a situation like this, I have even placed a lens like a panoptics in the sulcus with an optic capture. But that's because, and then put these patients on steroids and for a significant length of time, for about steroid eye drops for 3 months with NSAIDs. It does work out, but in this case, I'm doing the more classical thing of Sinskey hook.
So I think it turns out that a little smaller rhexis was a blessing in disguise.
Correct, correct. That's right. You're absolutely right. See the light, dekhiye, Maji? Very careful not to inject the lens into the vitreous cavity. Dialing hook. Jaldi, jaldi. I'm dialing the lens into the sulcus. Irrigation aspiration. And now comes the important part where we have to the vitrectomy part of this Centurion is also excellent. It gives up to 5,000 cuts, and you use you can use IA cut or cut IA mode. Light देखिए, बस हो गया. नहीं, बस हो गया जी. Now that aspect that you are talking about, to go behind and evacuate all the viscoelastic that's there.
What a wonderful surgery. Very nice, sir.
Can I have a Sinskey hook now? Yeah. I'm going to create an optic capture. The way it's become a little triangular tells me that ovalization of the rhexis tells me that's a good optic catcher that has been created.
Yes, sir.
And there is no need for the adjustment of the power of the lens saline. And it's important that I hydrate the wounds before I come out, because if the chamber shallows, then this optic capture may be released.
It's a wonderful, wonderful demonstration of a masterly act of managing a difficult situation. From word go on, this case was difficult from rhexis onward, and then
saline.
Yeah. So it wonderfully managed, sir. Must congratulate him. Everyone is like watching him with awe. Thank you for learning this kind of situation in a real time. is going to give a lot of insight to the learning surgeons as well as those who are learned surgeon.
I'm really sorry I didn't stick to the script, but then we had to make the best out of what we had.
Wonderful, sir. Wonderful, sir. So once you have finished, then we will have some more insight from you.
Yeah.
So one question is Dr. Ranjan is asking that once the PCR is there, so what should we do and what shouldn't we do?
No, once PCR is there, it's most important that we don't, go on with our irrigation aspiration and drag on the vitreous. It's extremely important that you deal with the, as you could see, the moment I saw that as far as the vitreous was not getting captured by my aspiration cannula, I went ahead and removed whatever cortical material was there, and there were some nucleus already there. Ideally, I should put some more viscoat, create a sort of a scaffold there, and then go ahead with the removal of the nucleus. And most of the nucleus I could remove, fragments that I could remove. But the moment I saw that the vitreous strands were presenting, immediately I switched over to anterior vitrectomy and removed it quite completely. And then after that, once the cortex was also removed, I verified, though once you have a circular rhexis rim, and you have a circular rhexis rim, and you have a pupil is also circular, that means there are no vitreous strands. It's always a good idea to put in some diluted triamcinolone acetate and then do an adequate, make sure that there are no vitreous strands that are left over. And in case there is, as I am sure there are a couple of small nuclear fragments that went in, and this is definitely needs to be removed, and it cannot be left there because this is going to cause a rise in intraocular pressure, vitreous floaters, inflammation, etc. And with the master vitreous surgeons that are available here, they can do a sutureless vitrectomy with a 25 gauge itself because it's a very tiny fragment that went in. And once we do that, of course, the patient does not have the benefit of multifocality, but with the good optic capture, with the three-piece lens in place, there's no change in the intraocular lens power that is needed. Based on only change has to be made based on the A constant that might differ. And once we do this, the patient is at least going to have reasonably good monofocal vision. And of course, follow-up of the retina with our retina vitreoretinal colleagues, at least for the next couple of years, is extremely important to make sure there are no problems. So not dragging on the vitreous is extremely important.
So the rent occurred during the removal of the last piece. I think there was no surge at all, so might be the one sharp edge of the nucleus has hit the posterior capsule, and that might be the reason. So what is your take on when we are taking this kind of hard nucleus, the last piece is to be removed, what precaution one should take?
No, I completely agree with you in the sense that, I was actually, I have had PCRs, but in this particular case, I was quite surprised. I was actually thinking of starting to discussing about the panoptics. I thought everything was under control. But, and as you also mentioned, as most of you saw, there was no surge. But I think that I don't believe that it was really the nucleus fragment which, it was not that sharp, and even for the endothelium can get damaged by the nucleus fragments repeatedly hitting there. But I don't think the PCR occurred there because of that. I think it's the surgeon's fault. Invariably, there must have been some movement forward of the posterior capsule which I missed, and then it happened in a fraction of a moment, changing the whole scenario.
I think that there must be some pre-existing posterior capsular dehiscence kind of thing.
There was no PPC, it was an intact capsule. I mean, I take the blame for it.
But so you did a good job in the end.
So one question, like when we are advising premium IOLs for such grades of cataract, so should we counsel the patient before also that during surgery if there is any problem, like we may not be able to put the lens, or is it like we should block these kind of patients all the time and then do, because it was a very hard cataract?
No, I completely agree with you. We have to forewarn these patients there might be a change where the posterior polar cataract, extremely small pupil, subluxated cataracts, all these situations, hard cataract like this, we have to forewarn them that there might be a change in script, you might have to do something else. But just because it's a hard cataract, I think we need not, and it was a well-dilated pupil, the patient was just about 63, 64, denying the benefits of a good technology like a panoptic toric is not right. But once you have a problem like this, then naturally you have to deal with it, and the patient should have, I'm sure, was forewarned that there could be a change in plan.
Sir, at this point of time, I think it's easier said than done, but when you're removing the last piece, would IUL, putting an IUL first and then removing the last piece would have been a good idea, but as I said earlier, it's easier said than done now.
No, you're absolutely right, Satyajit, in the sense that, if it was just a clean-cut PCR and vitreous was not already presenting, I would have done this IOL scaffold and then placed the lens inside, maybe not even in the back, but in the sulcus, and then with that support could have retained the nucleus fragments. But once vitreous had started already coming out, then I did not want to do that, because in that case, that getting the nucleus, the lens, and everything get mixed up is quite a mess. I have done this IOL scaffold. Sometimes you get a nice punched out hole in the posterior capsule, and the vitreous face seems to be intact. In those cases, pushing in a little dispersive viscoelastic like viscoat so as to tamponade the hole that you create, then place the intraocular lens and go ahead with the rest of the surgery. It does very well. But as you could see in this was a very large rent, just happened suddenly, and already vitreous was in the AC. In those cases, I think I would not doing an IOL scaffold, at least in my hands, doesn't work. I think that would cause a considerable traction on the vitreous base and may have other deleterious consequences.
So wonderful demonstration of a skill. Must say everyone to give a standing ovation to Ramamurthy sir. It was like playing on a Karachi pitch by Sachin Tendulkar or by Gavaskar. So wonderful demonstration of.
Thank you.
We'll move now to the next surgery, I think, with Ramamurthy sir.
The details for the next patient is he's a 20-year-old male who came to us for a refractive surgery, but his power in the right eye was plus 11 diopter and in the left eye was plus 10 diopter. High myope, high hypermetrope. So we planned the patient on the line of ICL lenses. We did a topography for the patient, but on doing other investigation, the ACD of the patient was less than 2.8. So the patient was thus planned for clear lens exchange for high hypermetrope. Over to sir for next wonderful case.
Can we now invite the panelist of the next session, moderator Dr. Nilesh Mohan. On the panel, Dr. Pranav Ranjan sir. Wahan, sofa pe. Dr. Ajay Sinha sir. Dr. Ajay Sinha sir. Abhi to yahin the. Abhi yahin the. Dr. Vishal Kishore, please. Dr. Pooja Sinha is on the way. Dr. Abhishek Ranjan. Dr. Abhishek Ranjan. Dr. Vishal Kishore, please take over.
Can you hear me?
Yes, sir.
Yes,
this is again a very controversial surgery. Patient is just 20 years old, has a plus 12 diopters in both eyes, plus 11 and plus 10 in both the eyes. And obviously, phakic intraocular lens would be the surgery of choice. Or you can't deal with the laser vision correction, this kind of a error. and but the AC depth is only 2.68, and the problem is that these lenses, hyperopic lenses especially, they are quite thick in the periphery. So not going, sticking onto the dictum of at least 2.8 millimeters and hyperopic phakic lenses at least 3 millimeters is extremely important. And obviously this patient is very upset about his +11 glasses. It's not just a quality of vision, but the quality of life itself changes with those thick phakic glasses. So he wanted some kind of a surgery, and Dr. Subhash has suggested to him to undergo this clear lens extraction. And at this age, maybe a trifocal lens or something would have been better. But as you know, at a +39 diopters which this patient requires, it's not possible to have a trifocal lens. It doesn't come beyond +30, or in some cases up to 35. So we are going to be essentially going a monofocal implant. So the patient might would require pair of glasses for reading. Subsequently, maybe a small residual power also would be there. We could discuss this later, but the other choice would be to fine-tune whatever once we have implanted this lens. Invariably, with these high powers, there can be errors in the biometry. So if there is any residual hyperopia, small hyperopia, or astigmatism, this could be handled with a laser vision correction. And finally, if the patient is very keen on getting a total freedom from glasses, even a piggyback lens, a trifocal, could be implanted. Of course, question of whether there would be space for implanting, because they are getting the case ready and we have time, I'm saying all this. For implanting a piggyback lens in a highly hyperopic eye like this would be something that you may ask. But the thickness of this lens, the natural lens that we are removing, is about 3.7 to 3.8 millimeters. And obviously when you remove this, there is enough space for even 2 lenses to go in.
So would you want to do a YAG PI in such cases where AC depth is less and hyperopic patients?
No, I don't see.
Not necessarily.
Not necessarily. The angles are open, so there's no risk of any raise in intraocular pressure. I had requested for IV mannitol 200 cc to be given half an hour before surgery. This case is again going to have a shallow AC, and I just hope everything goes according to plan. Let's see. Can you reverse this? The panelists can come up with their thoughts on the surgery, because this is a controversial surgery. How many of you would actually do this?
Sir,
sir,
good morning, sir. This is Dr. Pranav Ranjan, sir.
Hi, good morning, Dr. Pranav.
How are you, sir?
Very well, very well.
Not
too well after the last surgery.
No, last surgery was exceptionally
well managed. You have to be very proud
sir.
Of yourself.
Sir, that was very, very well managed, sir.
Thank you, thank you. See the light, dekhiye. Side put.
Sir, primarily the clear lens extraction surgery as of today is most popular in the angle closure disease kind of a situation, sir.
Yes, that's another side advantage of that.
Actually, next week I'm speaking on clear lens extraction in Dubai. Myome.
And that also particularly in the primary angle closure glaucoma cases, frank angle closure glaucoma cases. Right. So there has been a lot of study in which says that it really works well.
Main incision. I made my side port incisions. I'm going to make my main incision. एक जॉनसन्स बर्थडे दी.
Sir, here you have pretty much indications, but it's becoming quite a routine practice for many patients who are suffering from presbyopia and do not want glasses.
Yeah.
They're just going ahead with a clear lens extraction and getting a trifocal done. Sir, do you advocate that, sir?
Absolutely. You know, patients in their 50s Very often these are patients whose children have undergone a smile or some refractive surgery. They say, what about me? And if they have a plus 2.5, plus 3 diopter, needle, bend kar dete. So then they need plus 5 for distance. Then they get a plus 2.5 for reading and plus 5 for distance. Obviously, in these cases, doing a clear lens extraction does help them, and that's presbyopia lens exchange. But that's a definite indication. I think all of us would be okay with doing this. But this is a patient who is just 20 years old. I have operated on a patient who had a plus 17 diopters in both eyes, and more than 6-7 years back. And you know, he was amblyopic in one eye, had only best corrected vision of 624. But a very happy patient because since ki hook.
Must have changed his world.
Yeah. See the light dekhiye? Light dekhiye? Saline in the cornea.
Sir, this much red glow is without the retro illumination?
It's a combination of retro. I'll just talk about it just one minute.
Yes, sir.
Today doesn't seem to be a day for capsular excess for me.
It is your day. Everything is fine. You did such a wonderful job in the last case. Many would have been worried and they would have shifted the microscope. You showed us right till the end how a beautiful surgery is done.
Saline.
Sir, Rexis is absolutely circular, sir.
I do. लाइट देखिए भाई, लाइट देखो. Biscuit. Can we just have quadrant removal? Just quadrant removal. So all I'm going to do here is to aspirate, raise the vacuum to 500.
Yeah.
Dialing. There is no question of chopping here. Please raise the intraocular pressure a bit. Usually I keep my intraocular pressure at 30 only, but there's a tendency for the chamber to shallow. Usually the chambers are very especially with the last case, Jarasa. Just
So everything is out, sir.
Visco, aye.
Sir, there is one suggestion at this point, sir.
Yeah.
Even for the last case, when you are taking out the last piece, can we put a iris repositor in between the phaco tip and the posterior capsule, so that then whatever fragment is left is in between, is sandwiched between the two instruments. So posterior capsule gets extra amount of safety, because this I have been practicing and I learned from Dr. Subhash only. And I think I do it in every case. The last piece, I put the iris repositor between the phaco tip and the fragment. The posterior capsule is behind the iris repositor.
No, I completely agree. You know, I'm so confident of this machine that usually there is no fluctuation. It's a very steady chamber, and as you saw, I was using an intraocular pressure of just 30, very moderate settings.
Yeah, what you said here, this is a very, very shallow anterior chamber. So,
So
that could have possibly added some amount of safety. I mean, this
Yeah.
is what I feel, sir.
No, definitely all these small measures do matter, and especially when you have a problem, you always think that I wish I had done this. The bigger cartridge. Yeah. So I always favor a bimanual IA because I think that gives excellent access to the entire capsular bag. Light decay. And as regards this Phaco machine itself, I'm told the first Centurion machine in India was placed at Dr. Subhash's place. Truly congratulations to him for his foresight. But I think it's an excellent machine, especially with the active sentry also being incorporated in that balance strip, the active fluidics, the advanced integration that is being put to full use here, integration with the Argos, with the operating microscope, etc. And the active sentry with its unique irrigation pressure sensor in the proximal end of the Phaco probe are all excellent devices which adds to the great stability that we experience with these lenses. Once in a while on a bad day you end up with a situation like what I had, but that's extremely rare. And as you could see in the last case also, I could divide the nucleus with using reasonably moderate amount of power. Nowadays I don't use very extreme powers at all. Light decay.
This Rexis looks like a femtorexis.
So that is why I said it was absolutely circular. Sir, there are 2 points for making a Rexis, sir. Whether doing a Rexis with a cystitome or a capsular forceps, which is better, Utata forceps?
Sorry?
Making a Rexis with a cystitome or the Rexis forceps, which is better, sir?
No, frankly, I routinely make it with a cystitome, and very often it's just a 15-second job and you don't even realize it. But I see excellent surgeons who routinely do it with the capsular Rexis forceps. But I completely think it's a matter of convenience. But as you saw in the earlier case, whenever there is a tendency for the Rexis to run off, like when it starts pointing towards the posterior capsule, then it's a good idea to go ahead and I'm just waiting for the lens to be loaded. Use a micro Rexis forceps and scissors through the side port. And I slightly enlarge the incision because it's a 39 diopter lens, and obviously it needs a slightly the C cartridge for going in. And you can see it goes in a very controlled manner in spite of it being a very thick lens. And this is made up of the Clarion material, which is again, I think, with its 1.4% water content. And as you can see, the separation of the optic haptic also happens much quicker compared to the IQ in these cases. And this will be a life-changing experience for this patient. And
absolutely.
And getting a good Rexis overlap onto the lens is extremely important. Of course, the PC is not, even if a YAC capsulotomy is needed in these high hyperopic patients, you're not worried about the retinal issues. Usually they don't occur. But the greater issue is that of choroidal effusion. Light dekho bhai, light dekho. So we have to be wary of that. And if the retinochoroidal complex is more than 1.7 millimeter, then there are greater chances of this problem occurring. But that was more of an issue when ECC was to be done. Or jara saline chahiye. Saline chahiye. But now with Phaco emulsification, with smaller incisions, with more controlled fluidics, that's not really a concern. But I always like to, in this patient, light dekho bhai. This patient also, the chamber was a little shallow. It's around 2.6. But we had already given this mannitol 200 ml just before surgery, essentially to reduce any amount of upthrust which you can experience in some of these highly hyperopic eyes.
So you wouldn't want to suggest a trifocal in this, sir, or a EDOF?
No, obviously if it was available we would have suggested, but the problem is at plus 39 you don't have any company coming with a EDOF or a trifocal.
True.
You can have some Indian manufacturers doing it, but if you want a quality lens like this, then so what I would do now is to watch this patient, of course do the other eye in a week later depending on the outcome in this eye, and then if supposing small residual errors are there, that can be done on the corneal surface with the laser vision correction. In case he wants freedom from glasses also, even a presbyopic correction, we can slip in a trifocal presbyopic lens.
So very
wonderful surgery.
Wonderful surgery, very nicely.
Hi,
done.
sir.
Thank you, sir.
Sir, what is the chance of
yeah, please go ahead.
Secondary glaucoma in this case? Do you think PI is advisable in this case, surgical PI?
Not really. You know, we have replaced a 3.5 millimeter natural lens, which has anterior-posterior thickness of almost 3.5 to 4 millimeters, with a lens which is just about 1.2 millimeters. So automatically, when you replace this with a pseudophakic lens, the chamber deepens and the angles are also going to open up. So I don't think it's really necessary. So even, for example, even in elderly patients, when they come with a certain amount of cataract and slightly narrow angles, we don't think that lens extraction is treatment for angle closure glaucoma. But as a advantage, we say that instead of you can go ahead with the lens extraction, that will take care of your angle closure element also, and also you can benefit from freedom from glasses, as was discussed earlier.
So, sir, suppose this case is hyperopic. In case of high-grade myopia, whether other refractive procedure is not suitable, is there any posterior segment complication of this clear lens extraction?
No, I'm so glad that you brought up this question, because I absolutely against doing a clear lens extraction for a high myopia because of the significant posterior segment complications that can arise. And as you are well aware that, you know, the chances of the retinal tears and retinal holes whenever we replace the natural lens with an artificial lens, because of the greater space that is there and endophthalmodonosis that happens is much higher. And you can also macular complications. So definitely not for high myopia. Obviously for a -10 with a 2.6 millimeter ACD, of course you could have done a smile or some refractive procedure on the cornea. But if it was not, the cornea was not allowing that, I would just ask the patient to stick on to glasses or contact lenses. There are some cases where you have to say no. Clear lens extraction is for hyperopia.
When do you say no? So when, after how many diopters in high myopia you say no, we will not do a CLE?
See, for a -2, -4, -3, you have phakic intraocular lens or a clear or a procedure on the cornea. Just in case the cornea is not okay, you can put a phakic lens. And but essentially, I'm against the concept of doing a clear lens extraction. We are only talking of higher grades of myopia, that is -6, 8, and beyond. And in those cases, definitely doing a clear lens extraction is not a good idea. And if it's just a -2 diopter and the patient is not fit for phakic intraocular lens or for procedure on the cornea, a laser vision correction, the glasses are so tiny that the patient has to accept that.
So can we go with the 360-degree laser barrage in those cases where the refractive procedures are not suitable, and then after we can go with the CLE?
I think there are more competent retina surgeons who are there in the audience, but I'm sure many of them won't agree with this concept. I have discussed this with my years back, 20 years back. I myself used to do laser barrage. I've done that, but I don't think it has any beneficial effect. And you know, sometimes they say each of those holes themselves can open up as tiny tears when the vitreous detachment occurs. So I think it's a take-home message for the, you know, it's always very easy. Young surgeons may get tempted. They don't have access to laser vision correction. Phakic intraocular lenses are quite expensive. Why not just do a clear lens extraction? But I think it pays off in the immediate future. That is, the patient is happy, -12 glasses. He or she got rid of. But over a period of time, quite a few of them end up with, there is always a chance of retinal complications. There's a study which showed that, you know, once you do a clear lens extraction in a highly myopic patient, this was done of course in cataractous patient, chances of retinal detachment increases by 8 times compared to patients who are in emmetropic range. And once you do a yak capsulotomy, which might be required in these young patients, the chance of detachment increases by 3-fold. So it's almost, we are talking about 25 to 30% of retinal detachment in these young patients over their lifetime. I think that's not acceptable.
Thank you, sir. Thank you. We would like you to come over to this hall venue, sir, as the chief guest has arrived.
Thank you.
But thank you very much for the wonderful.
Thank you very much. Thank you. Thank you. Sorry.
We are very blessed today to have with us Dr. A.K. Grover, and we would be very enlightened if he speaks his talk on newer age presbyopia correction intraocular lenses. So over to you, sir.
Dr. Grover does not need any introduction. He is known very well throughout the country. He has been our All India Ophthalmic Society president also. But as is customary, we'll just introduce him. He has been awarded by Padam Shri. He is the president of the Oculoplasty Society of India. He is the general secretary of the World Society for Ophthalmic Plastic and Reconstructive Surgery. And he serves in the editorial board of the Asia Pacific Journal of Ophthalmology, which is a huge honor for India itself. And he and his center he is the examiner for the FRCS Glasgow, which again in itself is a big honor. He has received the Arthur Lim Award, and he has authored and edited 5 books and written over 80 chapters in textbook. And he has chaired session and been the guest speaker and performed live surgeries all over the world, not only in India. So it's a great honor and pleasure to welcome you to Bihar, sir.
Thank you, Dr. Satyajit, for those kind words. It's a huge privilege to be in Patna. Patna and Bihar feel like home. I've been here so often. And my parents have lived here, served in Bihar, so it is always a joy to come back. Thank you, Dr. Subhash and the Divyadrishti Institute for this invitation to be here. Grateful to see you all and meet all my friends in Patna. So independence from use of spectacles has become an important component of lifestyle which patients demand after their cataract surgery. So we'll be talking about the expanding presbyopia horizon with the new age IOLs and illustrate it with some cases. We will start with history now that I have 47 years nearly in ophthalmology. Let's see how things evolved in our lifetime. The first lenses were implanted, as we know, by Sir Harold Ridley, which was fiercely opposed, and it was spoken about as a time bomb ticking in the eye. And our Professor L.P. Agarwal used to consistently tell us during our postgraduate days that these are fads which will outlive their utility. But things have turned out differently. And this was with Sir Harold Ridley and his wife at the India IOL meeting, I think somewhere around 2001 or something, which Dr. S.R.K. Malik had organized. So the evolution started with the monofocal IOLs, and they were also quite primitive. Started with, as you know, with the anterior chamber lenses or the iris claw lenses and the various designs, glass and various materials, till it came to foldable lenses, and then we have had all these bifocal or trifocal or now the EDOF lenses. So the first multifocal IOLs were introduced in 1997 as multifocals, which were essentially bifocals, but then multiple focalities, trifocality came in, and variable add powers, which gave all the options to the surgeons. And then the toric lenses came in only in 2017. In my practice, our practice, the lenses, the presbyopia correcting lenses were only 5% in 2019-20. But by 22-23, when the trifocals came in and the halos and the glare became less of an issue, the numbers started increasing. Initially more trifocals, and now the pattern has shifted to be about equal EDOFs and multifocals. So what do we want to give to our patient, or what does the patient demand from us? He wants no compromise in his vision or visual quality as measured by the contrast sensitivity. He wants spectacle independence from all distances, and he doesn't want any abnormal phenomena. This is the ideal expectation. Of course, we are not able to achieve all of them. So, but let's look at what choices we have today. We have the monofocal option, which is probably the most commonly used, with one focus for far, which is the best visual quality as measured by MTF. Then we have these trifocals, which give us a peak at distance, intermediate and near. The visual quality at all three can be good. Then we have the extended depth of focus lenses, which avoid some of the drawbacks of the trifocals, but give us a focus only for far and intermediate. These are the true EDOF IOLs as they are classified. And then we have the so-called monofocal lenses plus, or the newer generation monofocal IOLs, which also give us a reasonable intermediate vision, something like N6 at 60 centimeters or 55 centimeters. So these are essentially the choices, and the two most commonly used optics for that are refractive and diffractive, which we all know about, but it will do good to reiterate them. So in the refractive, you have those refractive zones, which are divided into two or more with different refractive power. And the kind of light distribution that we will have depends on how much of each is present, the greater refractive power for near or the lesser refractive power for distance. And when the pupil alters, the zones may vary. The brightness ratio will become variable, and because there is an irregular diffraction at these zones, you had more glare and halos in these lenses. So largely they have been supplanted by diffractive lenses, which are essentially the same diffractive lens but with a diffractive microstructure with these sawtooth shape surface profile. When the depth of these is less than one wavelength, the length of one wavelength, then you get this bifocal effect, which is a near focus and a focus which is for distance rays. Here the pupil size does not matter because these saws are spread out over the entire zone uniformly, and the brightness ratio can be changed by how you create this profile. Now in the trifocals you have different diffractive steps which give different orders of diffraction. So zero order would give you for focus for distance, first order for intermediate, and the second order for near. So all these options have been created in diffractive trifocals. However, as we know, trifocals were a real step forward. They reduced the glare and halos as well, tolerance of the patients, but the quality is still not exactly what we want. The challenges are that these are based on concentric rings which can be appreciated in dim light, particularly by intelligent patients. They also get halos and glare as a result of that diffraction, and you have number of criteria that you need to fulfill. You need to make sure that they have no corneal pathology, you have no uveitis or no retinal pathology or macular pathology or an optic nerve pathology, and you need to meet those criteria before you take up a patient for trifocal lens. So the need for a newer IOL was therefore felt because patients demand improved quality of vision, and some of them may not be eligible for those trifocals, or some of them may be night drivers who are not so happy to have a trifocal lens which may have photic phenomena. They want a vision which is not compromised in its contrast or quality, and which bridges that gap between what they can get with a monofocal and what they can get with a trifocal, and that is where the monofocal plus lenses and the EDOF lenses fit in. So these extended depth of focus IOLs have the advantages because there are no diffractive zones, there are less glares and halos, and there is very little loss of contrast. But you do not get a good quality of near vision. You get an intermediate and a distance vision. So there are various designs or various principles that have been used. Spherical aberration is being increasingly used, leaving some spherical aberration or creating a negative spherical aberration. Both have been used to create that depth of focus. A small aperture or a pinhole principle has been used. Diffractive principle and refractive principles have all been used for the purpose. So examples of spherical aberration being used include the mini-well lens, which creates this zone of focus instead of a point focus. Small aperture optics, this was an example which is largely discontinued because you are not getting enough quantity of light going in, so there is a little compromise in that. Then you have examples of diffractive optics being used to create this depth of focus, but the disadvantage of the rings still remained, though the effect was reduced as compared to trifocals. And the refractive lens design has also been used for the purposes of increasing the depth of focus. But the Alcon came up with a new concept of wavefront shaping, which minimized some of the disadvantages of the earlier design. This is called the X-wave technology, which utilizes essentially all the energy, thereby not compromising with loss of quality or loss of part of the rays that you are getting, and you get an extended range with very little visual disturbance profile or very less of photic phenomena. So now what is the principle of this? The principle is that you have about just a 1 micron elevation in this 2.2 millimeter zone, beyond this 2 millimeter zone, which is causing the light to be focused differently. So those rays which are refracted or which go in through this area are shaped to focus earlier, and therefore there is a plateau which focuses differently. So you have the green and the purple rays or violet rays, they are going differently, focusing differently, creating that extended zone or continuous extended focal range, creating that stretch. And there is a plateau here which is making sure that this wave does not go beyond retina, is shifted forwards to be in the optical zone which you need. So this is the concept of the Vivity lens that Alcon has given, and the trifocal range provided by Panoptics and Vivity can serve as the two ends of the spectrum depending on the patient choice. So those who would like to avoid the photic phenomena totally, those who are night drivers, those who have early contraindications to trifocals can be taken up for a Vivity lens or a extended depth of focus lens. So like all lenses of this platform, the lenses are easy to place. So after you've completed your clearance, you can use the these lenses, place them in with a 2.2 incision, and as Dr. Ramamurthy was showing, the material is such that it goes in very comfortably and you can tuck in the lens in a single go in a very comfortable placement of lens through a 2.2 lens using a D cartridge. So some of the examples of scenarios where this lens is used is presented here. So this is a 35 years old young engineer with active lifestyle who developed steroids induced cataract because of use during COVID and had been having glare for the last 6 months with dense central posterior subcapsular cataracts. So he underwent cataract surgery with Vivity lens in January 22, had an unaided vision of 6669 and N6 at 60 centimeters. But he is happy with it. He is happy to do his night driving. He has not used any near glasses. The lifestyles have changed. We are much more doing the reading on our bright devices like phones or iPads and so on and so forth. And therefore the requirements, newspaper पढ़ने वाले तो हमारे generation वाले रह गए, तो अखबार कागज़ वाला अखबार. So that is the reason why many of them don't need near addition. So this is an example of another young patient. He had a CSCR in the central serous retinopathy or choroidopathy in the other eye, but the vision had recovered to 6.6. Possibly with someone like this, we would have avoided a trifocal, but he was insistent on a lens which could take care of his intermediate near needs. And the other eye had more cataract. He had a posterior polar cataract at this age. So we did go ahead with a Vivity lens. We have so far done the other eye only. We will be doing the other one. And he's a happy patient. This is a different scenario, a 65 years male, but he had macular pigment mottling and a few drusen. Again, indications where we would not do a trifocal. But for an extended depth of focus lens, we could agree because he wanted it, and we could give him a comfortable vision. Of course, he would have got a comfortable one with a trifocal as well, but we would have been possibly not happy to give it. Then there is the scenario of these younger patients. Now, this is an 8 years old boy with a traumatic cataract. Did not have corneal opacities. There was a concussional type of posterior subcapsular cataract, and we would not do a trifocal in a young patient. We have certainly not done any. But for a unilateral to have an anisometropia of the, and then give him a near correction for one eye would not be practical. So these are again scenarios where extended depth of focus lens can be a good choice. This girl had bilateral cataracts because of her steroids received because of her thalassemia major, and she had fairly poor vision, 624, 612. So here again, considering the requirements of the child, we thought extended depth of focus lenses we do use now in younger patients beyond those age of 7-8 years where a capsulotomy is possible, because PCO is likely to be more in these younger children. And for those, we are now considering EDOF lens, and we did put an EDOF Vivity lens in these, and she does use +1 for her near work for school, but otherwise she's happy, has some PCO now which we'll take care of with YAG. So these are some of the scenarios where extended depth of focus lenses have provided us with an option for those where we could not offer a presbyopia correcting lenses. So this was a talk essentially intended to give us this additional part of our armamentarium, and I would be happy to answer any questions.
Thank you, sir, for the wonderful insight into the newer presbyopic correcting lenses, sir. So just one question I would like to have with you, sir, share with you. if you are operating upon an ophthalmic surgeon, eye surgeon, what kind of a lens you will prefer for them, sir?
I think I would go by his choice, but if it was left to me, I would probably still think that I would like to give a surgeon a pinpoint vision rather than a range of vision, because there would after all be, this is not a pinpoint vision that is being given, this point is being converted into a zone. So this would possibly be, say, a patient who has a very bright 6/6 vision in the other eye. Again, you may not give this, because then he will compare the pinpoint vision that he has with the zone of vision that he is getting. So there may be some compromise. For a surgeon, I would possibly still prefer a monofocal plus lens rather than a EDOF lens.
Yeah, some kind of eye-hands kind of a lens.
Yes.
Yeah, okay, great.
Just I want to say about the history part. You have told that the first multifocal in 86 or something, or 90?
No, first multifocals came in
97.
97, yeah.
Just I want to tell my experience when I was doing fellowship in with Dr. Nagpal. First rigid PAMA multifocal after ECC was implanted in 1988-89 there. So just information.
PMMA rigid, maybe.
I think Pierce has implanted in 1986 first lens of multifocal rigid IOL, if I remember correctly. Okay, thank you.
Long history. We've been in ophthalmology now, Ramamurthy and me, for 46 odd years.
Sir, now where do you place the Crystal lens, accommodative lenses? Has it gone out of market? Because that is not heard of.
Now it has gone out of market because it was realized that the accommodation that it offered was only about 1.25 diopters and did not really serve any advantage. And of course the enormous cost that it had. So they went out of use within 3-4 years.
So any query from the audience, if anybody wants to ask anything, or otherwise, Satyajit, anything?
No. Inauguration karaya jata, sir ko late ho raha.
Thank you so much, sir.
Thank you.
Thank you.
A very good morning, everyone. We're now holding a brief inauguration for the Advanced Phaco Vitreoretina contoura Vision CME cum workshop. I'll request the Director of DDC, Dr. Subhash Prasad, to welcome our Chief Guest, Shri Nityanand Rai ji. I'll request the Director of DDC, Dr. Subhash Prasad, to welcome our Chief Guest, Shri Nityanand Rai ji, Honorable Minister of the State, Minister of Home Affairs, Government of India, by presenting a bouquet. I now request Dr. Vidhata Vidhu to present a bouquet to Dr. A.K. Grover, sir. I request Dr. Shivani to present a bouquet to Dr. D. Ramamurthy, sir. Thank you, everybody. As we prepare to embark on this auspicious occasion, it is customary to invoke the blessings of the divine by lighting the lamp. I request our esteemed Chief Guest, Dr. Nityanand Rai ji, our guest faculty, Dr. A.K. Grover, sir, and Dr. D. Ramamurthy, sir, the Director of DDEC, Dr. Subhash Prasad, Managing Director of DDEC, Mrs. Sangeeta Prasad, Dr. Ajay Paul sir, Dr. Gyan Bhaskar sir to please come forward and perform the solemn duty.
Dr. Ajay, President of Patna Ophthalmological Society.
Mrs. Sangeeta Prasad, please come forward. Thank you, everyone. Now I invite Dr. Subhash Prasad, Chief Consultant and Director of Divyadrishti Eye Center, to give a welcome speech.
And before that, I would like Dr. Ajay to say a few words. He is the President of Patna Ophthalmological Society. He should say a few words, please. Honorable guests, I am really honored to be present here amongst all of you. And thank you, Dr. Subhash, for being with us. Thank you, Dr. Ajay. Respected Honorable Minister of State, Ministry of Home Affairs, Sri Nityanand Rai ji, eminent ophthalmologist of our country, Padam Sri Dr. A.K. Grover sir, Dr. D. Ramamurthy sir, all faculties of today's workshop, my senior, my colleagues, PGs, persons from media, executive from Alcon India, ladies and gentlemen. Good morning to all of you and a very warm welcome to all of you to this meeting on advanced cataract, vitreoretina and contoura vision refractive workshop. I am so thankful to our chief guest, sir, Sri Nityanand Rai ji, who agreed to just plan his visit just for this occasion. Actually, he is so busy in Delhi, he doesn't have time, but he told that he will come, he will make some program to attend this. So I am so thankful, sir. You all know that Divyadrishti Eye Center was actually founded in 2002, and since then it has been organizing CMEs and live surgeries in time to time. And we have the team of, we as a team of Divyadrishti are so blessed to have privilege of hosting so many eminent ophthalmologists of country. And some of them are Professor J.S. Titial sir, Professor S. Khokar, Professor Rajesh Sinha, Dr. Dinesh Talwar, Dr. Mahipal Singh Sachdev, Dr. T.P. Lahane, Dr. Suven Bhattacharya, Dr. Nishikant Borse, Dr. Subhadra Jalali, Dr. Rajendra Prasad, Dr. Avinendra Gupta, Dr. Sunny Sen Gupta, Dr. Ratish Chandrapal, Dr. Narayan Bardoli, Dr. B.P. Kashyap, Dr. Partha Vishwas, Dr. Ashok Nanda, and many of our local colleagues from Bihar. In continuation of that, we are so happy to have amongst us two former AIS presidents and great academicians who are so well known not only in India but across the globe. Dr. A.K. Grover, who heads the Department of Ophthalmology at Sir Gangaram Hospital, Delhi, and Director of Vision Eye Care Center, is not only an international famed oculoplastic surgeon but a wonderful anterior segment surgeon, and we are going to witness his skills in few minutes from now. And above all, he is a wonderful person, a wonderful teacher, and so he is always so loving and he takes care of everyone, and we always love him, sir. We always look at you. So thank you, sir, for sparing your time despite the fact that you had a meeting yesterday evening in the Delhi. And Dr. D. Ramamurthy, apart from AIS president, was CSE of AIS for 2 terms and raised the bar of scientific activity of AIS. And he is the chairman of 22 hospitals, and he's so busy that he doesn't have even visit his hospital, but he actually agreed to come down to Patna and to demonstrate his surgical skills. We are so grateful to you, sir. And you just landed to India 2 days back from Barcelona, and again he went to Chennai to deliver, and again here to Patna. So hats off to you, sir, for your energy and the way you manage the case. I think that all the attendees have definitely learned a lot. Not only to see a good Phaco is important, but to see how you manage the complication is also important, and you have demonstrated it so well. Apart from these 2 geniuses, we have our own faculty who have some of them have displayed, and they are going to display some surgical tips. And please feel free to ask questions to them so that you can be benefited to the maximum extent. At the end, again, I want to welcome you from bottom of heart. Thank you so much.
Thank you, sir. Now we request the chief guest to give a memento to our following chief guests, guest faculties. So I invite Ms. Nityanand Rai ji to please come forward. I invite Dr. A.K. Grover, sir. I request the chief guest to give a memento to Dr. A.K. Grover, sir. I invite Dr. D. Ramamurthy, sir, to please come forward. I request Nityanand Rai ji to please wait on the stage. Dr. Ranjan Rai, sir, please come forward. Dr. Satyajit Sinha. Dr. Vidhata. Dr. Satya Prakash Tiwari and Dr. Bhulesh will be joining us shortly, and we eagerly await the return of our other faculty members. Thank you so much, guests. In behalf of I invite Dr. Shivani to please come forward and accept the memento on behalf of Dr. Bhulesh. Now I kindly request the DDEC Director and the POS President, Dr. Ajay Kumar, to please show their appreciation for our esteemed chief guest by presenting a token of gratitude in the form of memento and a shawl.
Good morning, Dr. Ranjan.
Good morning.
So, what I was telling that you are advocating
Subhash sir and Dr.
for
Ajay sir. I
increasing
request our
the
chief guest to address the
incision
gathering.
a little bit. Now,
सबसे पहले तो हम
Thank you, Dr.
दिव्यदृष्टि
Subhash sir and
पटना
Dr. Ajay
के
sir. I request our chief guest to address the
कुछ है।
gathering.
यानी कि उनके दिव्यदृष्टि के संस्थापक, संरक्षक, उनके ऑनर, सबसे पहले तो डॉक्टर सुभाष जी को हम बहुत बहुत आभार व्यक्त करते हैं। दिव्यदृष्टि पटना के बड़े आँख सब कुछ है, जो बीमारियां है उससे संबंधित दिव्यदृष्टि के संस्थापक, यूँ कहें तो ठीक है पटना के ऑनर ज़्यादा आए हैं, लेकिन डॉक्टर सुभाष जी को हम बहुत बहुत आभार व्यक्त करते हैं। चिकित्सक यहाँ पधारे बड़े और उनको के यहाँ बुलाने का इस कार्यक्रम के माध्यम से जो काम संबंधित हम लोग के लिए गौरव, यूँ कहें तो ठीक है डॉक्टर सुभाष ज़्यादा आए हैं, लेकिन देश भर के आभार अभिनंदन चिकित्सक इस कार्यक्रम को आयोजित करने के लिए और उनको और डॉक्टर का इस कार्यक्रम के माध्यम से जो काम किए हैं हम लोग के लिए गौरव का विषय है। डॉक्टर सुभाष बाबू जो यहाँ पधारे, नाम तो उनका सुने हैं, इस कार्यक्रम को मुलाकात नहीं हुई थी, आज मुलाकात और डॉक्टर सौभाग्य मुझको मिला है साहब। और इस यहाँ पधारे के नाम तो उनका सुने संदर्भ में और इस जगत की एक मुलाकात होने का सौभाग्य मुझको मिला है, मार्गदर्शन मिला और इस और मुझको भी आशीर्वाद के चिकित्सा के जो आपकी टेक्निकल संदर्भ में और इस जगत के एक मुझको समझ में नहीं आता का आप सबों को मार्गदर्शन, लेकिन इतना जरूर था और कि मुझको भी आशीर्वाद मिला इस बिहार की टेक्निकल बातें थी इनके दिमाग समझ में नहीं लाभ मिला है, लेकिन इतना जरूर हम लोग के लिए महत्वपूर्ण है। पधारे इस बिहार को अभिनंदन में आपको जो से इनके मार्गदर्शन से जो लाभ मिला है डॉक्टर ए.के. राम हम लोग के लिए महत्वपूर्ण है। पधारे हमसे आए, हार्दिक अभिनंदन मैं आप लोग से कर रहा हूँ। एक डॉक्टर को अपना डॉक्टर ए.के. रामामूर्ति साहब अपना अपना टूर से आए, पेशेंट छोड़कर कहीं जाना कितना मुश्किल होता है, डॉक्टर को अपना इतना तो क्लिनिक और अपना क्षेत्र है, इसलिए कि मैं पेशेंट छोड़कर कहीं जाना कितना मुश्किल होता है। सबसे ज्यादा तो अगर जरूर मुझको अनुभव है, इसलिए कि मैं रहता हूँ तो डॉक्टर पटना के सर्किल में अब सबसे ज्यादा चाहे इलाज के क्रम की ही बात नहीं करते हैं ऐसे डॉक्टर जगत ही जो जिनसे चाहे इलाज के क्रम की ही बात नहीं करते हैं ऐसे, लेकिन जो हमारी जिनसे मैं दिखाने के लिए जाता हूँ वो अलग बात है, लेकिन अलावा हमारी फैमिली सबसे ज्यादा पटना में अगर किसी का सर्किल होता है तो सबसे ज्यादा पटना में अगर किसी का सर्किल होता है बहुत मेरा सौभाग्यशाली हूँ, सर्किल हमारे इसलिए मैं बहुत सौभाग्यशाली हूँ। बैठे हैं यहाँ हमारे सबको यहाँ बैठे हैं, सबको यहाँ करते हैं अभिनंदन करते हैं। एक दो चीजें मुझको कहना है, एक दो चीजें मुझको कहना है कि ठीक है देखिए क्या आप अपने चिकित्सा के अपने अनुभव अपने विशेषज्ञता के माध्यम से बीमारियों को तो ठीक करते हैं और आँख है कैसी चीजें जिसके बिना तो जीवन की बात ही नहीं की जा सकती। आदमी को जिसको बोलते हैं कि जिंदा मौत अगर मिलती है तो वह जिसकी दृष्टि चली जाती है या दृष्टि हीन हो जाता है उसमें कितना महत्व होता है। इसलिए बहुत ही महत्वपूर्ण चिकित्सा क्षेत्र के आप लोग आए। एक आग्रह जरूर आपसे है कि इलाज से तो ठीक कर लेकिन बीमारी कम से कम प्रभावित लोगों को हो भी तो आँख सुरक्षित रह जाए, दृष्टि उसकी कामयाब रहे। इसके लिए आप कौन सी चीजें आपको जागृति के रूप में समाज को या लोगों के बीच देनी चाहिए, इसका जरूर प्रयास करना चाहिए, यह हम आपसे मेरा आग्रह है। दूसरा है आयुष्मान भारत। आयुष्मान भारत, अभी हम डॉक्टर सुभाष बाबू से पूछ रहे थे कि आँखों के इलाज में भी आयुष्मान भारत योजना का जो माननीय प्रधानमंत्री जी की बड़ी महत्वाकांक्षी योजना है, उसका लाभ लोगों को मिलता है कि नहीं, बता रहे थे कि मिलता है। तो हमको लगता है कि उसमें जितना हम लाभ दे सकते हैं आयुष्मान भारत से, इसलिए कि जिनके लिए यह योजना है उसके विषय में भी अपने क्लिनिकों में इसके संदर्भ में ज़रूर बताना चाहिए। और हर क्लिनिक इसके लिए अगर कहीं आयुष्मान भारत के लिए प्रयास करता हो, अगर कोई उसको प्रशासनिक स्तर से कोई कठिनाई होती हो, तो मैं तो यहीं का रहने वाला हूँ, मुझको ज़रूर बताइए। हम सब चाहते हैं कि ज़्यादा से ज़्यादा हॉस्पिटल आयुष्मान कवर्ड हो ताकि गरीबों का इलाज हो सके। और आपकी भी व्यवस्था, चूँकि हॉस्पिटल है तो व्यवस्था तो चला नहीं है, तो उसमें आपको कहीं कोई कठिनाई नहीं हो। एक चीज़ मैं ज़रूर कहना चाहूँगा कि अभी का जो समय चल रहा है, यह अधिकार से ज़्यादा कर्तव्य काल हमारे प्रधानमंत्री जी कहे हैं। क्या हमारा कर्तव्य काल है? 100वां वर्षगांठ जब हम आज़ादी का मना रहे हों, उस समय भारत स्वस्थ भारत हो। स्वस्थ का मतलब ये नहीं कि कोई बीमार नहीं पड़े, वैसा मेरा नहीं कहना है। एक स्वस्थ भारत यानी एक देश को स्वस्थ देश होने का जो एक पैमाना होता है। शरीर है, बीमारी तो होगी, पहले भी हुई थी और आगे भी होने वाली है, आज भी है, लेकिन एक स्वस्थ भारत बने, इस दृष्टिकोण से हम सबको देखना चाहिए। और कर्तव्य काल है, इसलिए मैं एक और आग्रह करूंगा विनम्रपूर्वक कि सभी चिकित्सक या हॉस्पिटल एक स्कूल को जरूर गोद ले, एक स्कूल को। और वह स्कूल नहीं जो बड़े बड़े स्कूल हैं। हमारे बच्चे हैं तो कहीं कोई प्रॉब्लम हुआ तो कहीं दिखा लेंगे, लेकिन बिल्कुल आप सरकारी स्कूल को लीजिए या कोई बिल्कुल सरकारी किसी स्कूल को लीजिए और वहाँ आँख से संबंधित बीमारियों की जानकारी आप बच्चों को जरूर दीजिए। इतना कोई एक स्कूल जो ले सकते हैं, हो सकता है कि जो स्कूल में आप पढ़े हो या सरकारी हो तो ज़रूर उसको लीजिए, सरकारी नहीं है तब भी लीजिए, या तो अपने पढ़े हुए सरकारी या गैर सरकारी स्कूल जहां आप शिक्षा किसी न किसी प्रकार से प्राप्त किए हो, तो वहां प्रतिबंध नहीं होना चाहिए कि हम सरकारी ही लें, या जहां पढ़े हों। और या फिर अगर वहाँ नहीं लेना है, सुदूर गांव है वहाँ हमको, या कहीं दूर हम आ गए या चले गए, तो फिर अपने आसपास के एक विद्यालय जो जहाँ, मेरे कहने का अर्थ सिर्फ इतना ही है कि जहाँ गरीब बच्चे ज़्यादा हों, उन गरीब बच्चों के वहाँ हम अगर कुछ कैंप लगा सकते हैं, कुछ उनका आई टेस्ट कर सकते हैं, नहीं भी तो उनको थोड़ा सा हम कोई साहित्य लिखकर उसको हम 4 लाइन के कुछ ऐसी चीज़ से सावधान कर सकते हैं जो बच्चों के आँख का नुकसान नहीं हो, हम कैसे आँख को धो सकते हैं, कौन कौन चीज़ से हमको बचना चाहिए और हमको क्या करना चाहिए, कहीं किसी प्रकार का लक्षण हो तो तुरंत डॉक्टर के यहाँ जाना चाहिए। इस प्रकार की कुछ चीज़ों को हम जरूर अपने लें तो मुझको लगता है कि गरीब का भी भला होगा, कर्तव्य काल के हम संदेश को भी पूरा करेंगे और 2047 तक भारत वैसा भारत जो दुनिया में सबसे ज़्यादा प्रति व्यक्ति आय वाला भारत बने, एक समृद्धशाली और सुरक्षित शांतिमय भारत बने, ज्ञानवान भारत बने और सामर्थ्यवान भारत बने, उसमें स्वस्थ भारत की उसमें सबसे ज़्यादा है। इसलिए कि विवेकानंद जी कहें कि स्वस्थ शरीर मन में ही स्वस्थ विचार विद्यमान हो सकता है। इसलिए आप बहुत महत्वपूर्ण हैं और मैं तो लगता हूँ कि कहीं भी अपने चिकित्सक विद्वानों के बीच होता हूँ तो जरूर इस बात को कहता हूँ कि अपने भारतीय विचार में 4 भगवान का दर्जा प्राप्त 4 लोगों को है, 4 वर्ग को है, 4 लोगों को है। एक माता पिता, एक माता एक पिता, एक गुरु और एक डॉक्टर। भगवान इसी 4 को न मानते हैं क्या अपने भारतीय विचार में, और यह चारों में अलग अलग चीज़ें विद्वान हैं, लेकिन एक डॉक्टर ही ऐसा पेशा है जिसमें चारों भगवान का अवसर भी मिलता है और गुण भी है। हर डॉक्टर माता पिता हो सकते हैं, माने पिता हो सकते हैं और माता हैं, हर डॉक्टर माता पिता तो हैं ही ना, माता भी हैं पिता भी हैं, और हर डॉक्टर गुरु है। कहीं न कहीं आप पढ़ाते भी होंगे, हो सकता है कुछ नहीं भी पढ़ाते होंगे, तो गुरु का स्थान लेते हैं आप। माता पिता जब इस सृष्टि में है तो माता पिता बनते ही हैं और डॉक्टर हैं ही, इसलिए 4 भगवान के दर्जा प्राप्त में चारों स्थान पर डॉक्टर होते हैं। इसलिए आपका स्थान कितना उच्च और पवित्र और कितना महत्व का है, इसका एहसास हम सबों को तो है ही और रहना भी चाहिए। लेकिन यह जीवन जीने के पद्धति में इस भाव को लेकर जरूर हम अच्छे मनोभावना से काम तो कर रहे हैं, लेकिन अगर लगे कि कुछ और हम कर सकते हैं तो इस पर विचार करना चाहिए। और हमने 2 आग्रह किया है, हमको लगता है कि मेरे इस आग्रह पर, अनुरोध पर आप विचार करेंगे। बहुत बहुत धन्यवाद। फिर से आप सबों को स्वागत, अभिनंदन और अपनी ओर से आभार। धन्यवाद।
Thank you so much, sir, for your enlightening speech. At last, I would like to invite Dr. Shivani to please give the vote of thanks.
We are highly honored to have such a wonderful gathering on a Sunday morning. We are grateful to our chief guest, Sri Nityanand Rai ji, for gracing us with his presence. We are blessed to have 2 great guest faculties, Dr. D. Ramamurthy sir and Dr. A.K. Grover sir, who spared their valuable time. We thank all the delegates who have arrived here for gracing this occasion. We thank all the media people, audiovisual team, AVR hall staff, our OT staff and the entire DDEC family for jointly putting efforts in making this workshop a success. Thank you.
This concludes our inauguration ceremony. I request Dr. Abhishek Anand sir to take over for the scientific session next.
I think it's also a very important occasion for Divyadrishti. And Dr. Sonali, can we have you in the front, please? I would like to very warmly welcome from Bihar Ophthalmic Society, on behalf of all the doctors in Bihar and on behalf of all the doctors in Patna for joining Divyadrishti. A very big congratulations to you and to Vidhata. Where is Vidhata? Is he here? A very warm welcome to you to Divyadrishti, to Bihar. And you have all our blessing for a very, very bright future. You have made the best decision in your life to join Divyadrishti, and you have a very bright future. Welcome to Bihar.
So thank you all. Let's begin with our scientific session without waiting much time. On the panel, I would like to invite Dr. J.J. Agarwal sir, Dr. Sunil Singh sir, Dr. Sudhir Kumar sir, Dr. Sivendra Sai and Dr. Vivek to please join on the panel. So on this, in this session, we have a live surgery on VR by Dr. Satyaprakash Tiwari and followed by a live surgery on Phaco by Dr. A.K. Grover sir. And then we'll have a talk on optimizing outcome in modern cataract surgery by Dr. D. Ramamurthy sir.
We'll shift the talk a little bit. Okay. There will be slight change in the talk, so we will prepone the talk by Dr. Ramamurthy before surgery by Dr. Grover sir. But right now,
okay, so we all know Dr. Satyaprakash Tiwari is a phenomenal vitreoretina surgeon. He's director of Drishti Punjai Hospital and he's done multiple live surgeries. And over to you, Dr. Satyaprakash. Can we have a brief introduction of the case? Dr. Satyaprakash, can you hear me?
Yeah, you are audible. Am I audible there?
Yeah, you're perfectly audible.
Thank you so much. So I'm going to operate a lady of right eye retinal detachment RD. The history is of about 2.5 months, so it's a little bit old RD with grade B PVR. But there is a superior hirsute here which I am going to show you just now, and I think we are going to provide her what best we can give her. So I am going to start my case. If my view of microscope is visible over there or not.
So we don't have the view of your microscope, but right now we are having the slides of the patient.
I introduce my system. So I'm going to operate on here. I'm having a microscope by Carl Zeiss Lumira T, and there is Indian-made viewing system, 3D viewing system called Ion, and the vitrectomy machine. Yeah, now my view is visible. So vitrectomy machine is Elcon Constellation tabletop, and I'm using HyperVit 20,000 cut rate, the newly introduced system. And I have already introduced 2 trocar cannula, one is infusion and one is working port, and I'm now introducing the 3rd cannula. So this is my system, 3-port 25 gauge pars plana vitrectomy. So once I establish the all my 3 ports, I would do anterior hyaloid, clear the anterior hyaloid area from the vitreous. It's a pseudophakic patient. Can I have the infusion on? Infusion is not on. Yeah. So first I will clear the anterior vitreous, and then we will go inside with the biome, and then I can show you the status of the case. Biome, please. Inverter.
So now we have good viewing systems from India also. A lot of good companies from Appasamy, Aeon, and many other companies, Reticare. So now we have 3 options of.
Dr. Abhishek, I think the large horseshoe tear is visible. It is just above the optic nerve head.
Yeah,
around.
so just for the viewers, the inferior that you are seeing is the superior side, and on the screen, and on the superior what you are seeing is the inferior retina. So this is a superior horseshoe tear.
So whenever we are operating a reg RD, we should first cut around the break so that it clears and makes the break free flow, and the fluid behind the break or behind the retina generally comes out and retina flattens immediately, and that helps us a lot to do the rest of the vitrectomy. So this is the way to do, that is clearing the break first, and if possible cut the flap also of the tear, so that becomes the hole becomes circular, and now the hole is completely free of vitreous. Now we are removing the core. Since there is a horseshoe tear, I presume that there is PVD. But still we would put triamcinolone acetonide to check whether there is any residual cortical vitreous is there over or not.
Dr. Tiwari, can you just shift your microscope a bit, you know, because we are seeing it's a bit slightly deserted on this screen. You must be seeing it perfectly, but
yeah, actually there is a capsular opacity superiorly, so that is hampering my view. That's why I have made little off axis to see that view. Can I have the tricot?
So do you regularly use tricot in all your cases?
Not all the cases. If I am sure that there is PVD, I am generally not using. But in this live surgery, I wish to show the youngsters that you should try to check with triamcinolone acetonide that whether there is PVD or not. Since see, what we have been taught that what is horseshoe tear? Horseshoe tear is a PVD induced break. Since I am getting a horseshoe tear in this patient, so it means there is PVD. But still, for a confirmation, we need to check so that we may not land up a re-surgery.
Yes, and especially it's an old patient and pseudophakic, so the chances of PVD already being present are quite high.
Yeah, all those things indicate that we are having already a good PVD. So, and those PVD actually makes the case very easy.
Yeah, looks like complete PVD is present.
Yeah, and inferiorly I can see there is a lattice also, and the edge of the lattice.
We are not able to see the inferior retina somehow on the screen.
Yeah. Actually, there is, I think there is some incoordination in between the view of the microscope and then this biome. Because I am able to see, and I don't know why the view is not visible.
So how will you rate this biome? Because you must be operating for the first time on this biome, right?
Yeah, it's good. I can say that for the beginning, because nowadays the cost of biome is going so high.
Yes.
That for a beginning surgeon, it's becoming Actually, the investment cost of biome is becoming as equal to a microscope.
Yeah. So it's a decent microscope with a good view, a decent biome. That is what I would like to say.
I would prefer the biome. For a retina surgeon, biome is more important than going for a high-end microscope.
And this appears to give a very good view and crisp.
PFCL, please.
Do you regularly use PFCL in all cases?
No, not in all cases. But since this is a old case and lot of PVR, grade B PVR, there is no star fold or some membrane visible. So I would see if I need to peel around the macula so that at least macula remains nice and clear post-operatively. That's why I am trying to put PFCL. I would try to peel the macula. In Arvind, our teaching was to put PFCL in each and every case. But here I am using PFCL in less than 10% of my Reg RD cases.
So we have completed the peripheral vitrectomy, it seems.
Yeah.
Are you going to use indentation to do?
Yeah. First I am clearing whatever possible without the help of indentation, and then I would request my assistant to indent. So the parameter I am working on is its hypervit 20,000 cut rate from Elcon Constellation, and they have given me full cut rate, and suction I think is 150. This is safe mode vitrectomy.
So for periphery, you are using 150 to 200, right?
Generally, I am keeping in my setting. I am keeping 600 only, and I am controlling the cut rate with foot switch only.
So,
but here the purpose is to show the ideal teaching techniques of Reg RD. So while doing save, we should keep our base that suction should be minimum. I have seen some of the surgeons using even up to 50 suction rate, just 50.
Yeah, but then 50, it's very difficult for the vitreous to get aspirated and.
Yeah, but the aim is that not to create any unnecessary break.
So ideal, I think, would be around 150 mm.
Yeah, 150 is nice. In this system, the system is so safe that even we easily operate at 600, and we control with foot switch. Whenever we feel that we need more traction, we just press the paddle, and whenever we think that okay, now it's fine, it's aspirating, then we keep operating at lower suction. So once you are having enough foot coordination, foot hand-eye coordination, then you can manage the suction with your foot switch also. Indentation, please. Prince indent. There is lot of peripheral vitreous here, so I am taking help of my assistant.
So ideally, before indentation, would you like to do ILM peeling, or would you like to?
Whenever we are planning ILM peeling, we are generally doing before indentation because the view is clearer in early phase of vitrectomy. And later on cornea becomes hazy or edematous, then peeling becomes difficult.
Because of indentation, sometimes the corneal edema sets in.
Yeah, and even for the time of surgery also, like if we are operating for 30-40 minutes, then cornea otherwise also becomes hazy. In this case, I think the macula looks nice, so I think I can manage even without peeling. So let me decide after doing.
Yeah, that is what I mean, on our view, it looks nice and pristine.
Yeah, that's why I changed my mind that, okay, let me first do the base, and then if needed, I would peel, otherwise I will leave it. चलो दूसरी जगह.
So in cases of retinal detachments, rhegmatogenous retinal detachments, in a pseudophakic eye, what are the things that concern you? Like, I mean, a lot of times we see a lot of peripheral opacity. What should be the ideal, position of the haptics? So, like, there are multiple times when you send a patient that you get operated for cataract surgery followed by a retina surgery. So, in which axis would you like the anterior segment surgeon to place their optic haptics?
See, nowadays with these all good biomes, that haptic position doesn't matter much.
Okay.
But one thing I would make sure that if it is a case of PCR, then the vitrectomy and FAE becomes difficult. So if I find that there is a significant PC tear and lens is unstable, generally I do not do FAE before, and I would put full PFCL and I would do laser under PFCL. And once I have done laser, then I would do FAE and exchange it with the silicone oil. And if the lens is stable and there is no PC defect, then I would settle the retina with air and then do laser under air.
So my second question is that let's assume a case is planned for cataract surgery followed by retina surgery. And the person who is doing a retina surgery wants another anterior segment surgeon to do the surgery. So what are the precautions and that you would like to expect your anterior segment surgeon to do when they are doing an anterior segment surgery as a preparatory surgery for a retina surgery?
See, they must suture the main port.
So suturing the main port once you complete the surgery, once you put the lens. So that is very important.
And if possible,
yes.
Do the superior surgery, because temporal, we are putting the inferotemporal trocar first. So if there is a temporal incision, main incision, sometimes that leaks and makes the entry of trocar cannula difficult.
Yes. So superior surgery is preferable if a retina surgeon is sending you patient for a preparatory cataract surgery. So preferably superior, and post completion of the surgery, suturing of the main port.
Yeah.
I just want to add one more point, that when the ports are made superior and during the time of indentation, if there is a sallowing of the chamber, then it's easy to put visco from the superior port rather than if the port is temporal.
Yeah, definitely.
So that is why I would prefer a superior incision over a temporal incision.
Definitely.
So right now we are in the indentation phase of the surgery, right?
Yes.
Preferable in such cases. A larger axis in these cases where a vitreoretinal surgery is contemplated. Larger than 5.5.
Yeah, so that there is no capsular phimosis and all these things.
CD नहीं, that is indentation. Choroidal detachment नहीं, indent कर रहा है.
There is no CD. This is just due to indentation effect of this myosis.
Dr. Tiwari, so post like preparatory cataract surgery, would you like a larger rhexis or a relatively smaller rhexis?
See, rhexis should always be around 5.5 to 6. In all cases, I think. Lesser rhexis is always going to cause problem. But if we are having very big rhexis, then sometimes lens may come out of the bag.
Yes.
And so we should balance actually the size of the rhexis.
So during indentation and during the post-operative time of tamponade, the lens sometimes decenters if the rhexis is pretty large. That is what I feel.
Yeah.
So
all these points are very well taken.
At least 1 mm it should cover the optic. That is what I feel.
Definitely. Not more than 5.5, around 5.5. Fluid change करिए, fluid खत्म हो रहा है क्या?
Like diabetic cases, where we are expecting that the patient may go for PDR, okay, and that patient is undergoing a cataract surgery. That patient should have a larger axis than 5.5 because the peripheral capsule will opacify later on, and if the patient needs a procedure, even a laser procedure later on, it will become difficult. So all these cases where a vitreoretina procedure is contemplated later on, may be contemplated, those cases should have a larger axis, larger than 5.5, because 5.5 is the normal size which people are doing. So a diabetic patient undergoing a cataract surgery.
So what should be the ideal size?
I think it should be more than 6. A little bit, at least 6 or 6.5.
So they should cover the optics, sir. Ranjan sir, what is your opinion, sir? What is your opinion, sir?
So overall optic diameter is around 6 millimeter. So if it is more than 6 millimeter,
for those we need a larger rexis so that later on if a laser procedure also has to be done. For example, patient has developed a PDR and we need to do a PRP for those patients. So if the peripheral capsule becomes opacified, it becomes difficult to do a laser for those patients. So all those cases where a VR procedure may be contemplated. Or for that matter, you know,
I think vitrectomy is now well completed.
I think in between what we are talking about the size of rexis, it is the transition zone from the phakic to a phakic area in a pseudophakic eye, which is going to give you different depth of focus to do the peripheral laser. It's not the size of rexis per se. It's not the size of rexis per se. Okay.
So now we are proceeding with doing a fluid air exchange, right, Tiwari ji?
Yes.
So you are using the vitrectomy cutter itself to aspirate from the superior Hausu tear, which has been converted into a good. The flap have been cut, and so now a good whole sort of thing.
Yeah, I am doing little bit of interface vitrectomy also.
So, like post indentation, you have done a good vitrectomy already. Now, is there any role of interface vitrectomy in such good indented eyes? Now you have completed it.
See, vitrectomy is never complete. Vitreous is such a sticky thing that how careful we are doing, and if we are doing again indentation vitrectomy, some sort of vitreous we will find.
Yeah.
So how much we can clear is good for patient, like the maximum what we can do.
Yeah, that is the same argument, no? That you are saying that vitrectomy is never completed, whatever you do. So even if you do interface vitrectomy, there will be some vitreous which will always left.
Definitely, but I have reduced the load of vitreous as much as possible.
I think at this point we are differing a bit because I feel that once you have completed, now I am using more indentation to just look at if there is any peripheral break or not, because chances more you spend time outside, sometimes there are chances that you create some iatrogenic breaks or something like that.
That possibility is always there. And that's why in my practice I am doing always 360-degree laser. Even if it is a single break, give me fluid direction, that soft tip.
So so this is where I also differ from you. You are using 360-degree endo laser in all your cases, right?
Yeah.
So
even non-RD cases, like if I am operating a macro roll, and after doing it 23 gauge,
so do you
25.
So I don't do that. I just do the laser of the break. That is it.
Abhishek, do you use peripheral belt buckle? When do you want to use belt buckle?
Me? PVR. So, Dr. Tiwari, are you using peripheral band buckle in your RD cases?
In few select cases, like if I am seeing, recently I operated a young engineer from IIT, and he was having at least 20 lattices all around the retina in the periphery, and that was a reg RD. So it was easy vitrectomy, but still I put a belt buckle because I wanted to give him additional support. So in all such cases, phakic eye, lots of peripheral lattices with vitreous looks unhealthy or sticky, then I generally try to put band all around to give the patient additional support.
So I think fluid air exchange has been done and retina appears to be well settled. So again, a wonderful case, almost on the verge of completion, Tiwari ji.
Yes, I have to do laser only, and then I would put silicone oil.
Any inputs from the other OT? What is going on?
Sir, I had one question.
Yes.
If a patient is phakic, then do you decrease the amount of indentation for the peripheral vitrectomy or?
No, I increase. Generally, I increase because the chances of lens touch is more if we are doing unindented base dissection. So generally, I increase the indentation. I ask my assistant to increase the indentation.
Especially superiorly, did you have any experience of lens touch while doing?
See, superiorly, generally, what happened in what? Okay. Generally, superior, you won't find the lens touch. What happens? Lens touch happens. Give me laser on kari. Generally, lens touch happens when we are negotiating inferior part of the retina from opposite direction. Like if we are operating with right hand and we are approaching the left side inferior periphery, then generally that lens touch happens. So what is the way? Either you do same side base clearing, right side of the inferior periphery from the right hand or left side from the left hand, or you do more indentation so that once we indent, then the chances of...
Yeah, Dr. Vedanta.
Sir.
Can you hear me?
Yeah.
So what's the news from the other OT?
The patient has been prepared, just few minutes. Sir is taking a look.
Can you give a brief introduction about the patient?
Yeah, the second the patient that is going to be operated by Dr. Grover, sir. It's the IOL that he is going to put is trifocal. The patient is 67-year-old young lady, old lady, sorry. The left eye has vision of 624 and K1 reading is 42.80 at 91 degree. K2 44.91 at 1 degree. Astigmatism minus 1.88 at 90. Total K minus 2.11 at 91. Axial length is 22.04 millimeter. The IOL power 26.5 diopter with 3.75 at 4 degree astigmatism. The fellow eye is pseudophakic.
So what was the lens put in the fellow eye?
The fellow eye, I'm not sure. Okay. We are not sure actually.
Yeah, must be the toric organ.
Yeah.
So can we have some video feed from the other OT? In the meantime, Dr. Tiwari is going to do, I think the indolaser has started.
Yeah. I have lasered the inferior lattice, now I am lasering my superior break.
So the take-home message from this point is that once you have done a fluid air exchange, you do the lasers of first the primary pathologies, that is the break and the lattice, and then you move for your prophylactic laser. Like in this case, Dr. Tiwari is going to do a 360-degree indolaser. So you first, because you don't know in retina when your view might get hazy or obliterated. So first you complete your intended primary sites and then you do this. So we can see he is completing the indolaser at the horseshoe tier.
Very valid point, Dr. Abhishek.
And what tamponade you are going to use?
Silicone oil.
Okay.
Silicone oil.
Okay.
Since it is an old RD, I am comfortable with oil. If the same case would have come 1 month back to me, 1 month before, then definitely I would have gone for the gas.
Dr. Tiwari, can we shift to the other OT and in the meantime we can join you back?
Yeah, no issues. My case is finished.
Yeah.
Like everything I have shown, I have to just show the silicone oil injection.
Yeah.
So from my side, there is no issue. The camera can be switched.
Thank you, Dr. Tiwari, for a wonderful case.
Thank you, sir.
Just few minutes, sir is getting washed.
Okay, so we
laser का power बढ़ाइए थोड़ा.
So as Vedanta has already said details about the patient, so she's a 67-year-old female and she came to us with diminution of vision since last 6 months with vision improved to 624. Her keratometry reading in K1 was 42.80 at 91, K2 was 44.91 at 1 degree. There was astigmatism of plus 2.14 at 5 degrees. Axial length of the patient was 22.04 mm. And the IL power that they have taken is 26.5 diopter. And it's a trifocal toric at 3.75 at 4 degrees. The fellow eye is pseudophakic and we do not know the brand or the name of the lens of the other eye.
कितना देर लगा सर्जरी में?
(29 minutes 32 seconds, Tiwari.
Generally, if I am operating in my operation theater with my system, generally 15 to 20 minutes is enough.
That is just incredible because you are operating in a different system. You are working on a Resite system, so good adaptability.
And that is fully automatic. Like I don't need assistant.
Yeah.
Everything is under my hand and foot controls.
Yeah.
Wonderful surgery, Dr. S.P. Tiwari. You are actually, he is telling Dr. Abhishek that you are operating in some other place. I would say that you are playing on home turf.
Yes,
yeah,
sir.
This is the OT from where you did the first live surgery of the Bihar, and this is the OT which has given you a lot of experience and exposure also.
And the same machine also, sir.
Yes. So you can see that the Tiwari has done a wonderful surgery, and we are so thankful to you for coming and doing a wonderful piece of surgery. And we'll always like to welcome you in DDC as a guest faculty, and every time you have to show the torch to the new generations, like many seniors have been showing that.
Thank you so much.
Do we have feed of second OT, the OT number 1?
Yes, sir. We are almost done.
If any time you feel that there is some delay, we can go ahead with the presentation of Dr. Ramamurthy, sir.
No, sir. We are almost ready.
Almost ready? Then okay.
Just a minute.
एक्सट्रूजन देना थोड़ा सा.
Just now somebody was asking what was the lens implanted in the other eye. This is one of the patient who was operated in last live surgical workshop, and Dr. Rajesh Sinha has operated in other eye also. Is panoptics lens implanted about 2 years back. So this is the other eye of the same patient.
So the patient is live surgery specialist also.
Yes. This patient is targeting live surgeries की कहाँ पे क्या हो रहा है वेट किया जाए प्रीमियम लेंसेज तभी मिल रहा है.
So I am done with silicone oil injection.
So welcome.
Actually, she is mother of one of my staff, important staff.
So Varion registration done. Okay. Okay. So we are starting off with the surgery now. The Varion registration has been done. This is a toric lens to be put in. She had a 2.34 diopters astigmatism. So with a steeper axis, which is now 4 degrees for our IOL. So this is the cystotome that I am getting oriented to this microscope. Okay, so the first important thing is not to damage the tip when you create this, because if the tip is blunted, then you can't do a good rexus, your control decreases. And then give a subtle angulation to this without a bend. लो अब मुझे 15 डिग्री नाइफ चाहिए नहीं मुझे forceps दे दीजिए. So this is a patient under topical anesthesia. She has a hard cataract and she has a astigmatism.
हाँ एकदम 20 घंटे.
Press okay. सीधा लाइट के अंदर आपको देखना होगा. She has a little shallow anterior chamber and she has a small anterior segment. Light के अंदर देखिए आप, light के अंदर देखिए. So I'll first getting oriented to this microscope. Yeah. So create a little groove here. लाइट के अंदर देखिए, लाइट के अंदर बल्ब को देखना है आपको, ठीक है? अभी वो ऑफ कर देंगे वेरियन का ये डिस्प्ले, या and then we'll create a side port. Now this side port is at an angle of about 1.5 clock hours. Phenocane दे दीजिए. We're using phenocane as the pupil is only about 6 millimeters. It won't dilate further. So अब इसको दे दीजिए मुझे, methyl cellulose दे दीजिए. So I want to pressurize the chamber before I make my main port, because that gives a more controlled incision. 2.2 knife दे दीजिए. So now the groove that we had made. Now this groove is made almost at the limbus, so that if you have a little bleed from it, it's a good sign. And then you go to about 1.5 millimeters and then change the direction so that you go iris parallel, and maybe 2.2 से 2.3 कर लेते हैं, so that we don't compress the wound when doing wound assisted delivery. Using light की तरफ देखिए, हाँ. नहीं लाइट में देखिए, आँख को नहीं हिलाइए, सीधा बल्ब की तरफ देखने की कोशिश करिए. बल्ब दिख रहा है आपको? हाँ, उस पे देखिए. थोड़ा मिथाइल सेलुलोज दे दीजिए वूंड पे. ला नीडल. लाइट की तरफ देखिए, बल्ब के अंदर देखिए. So we are now going to make a capsulorhexis. So first incision is only about 1.5 millimeters, so that when you lift it, it becomes 2.5. And you're going to do work on the inner surface. And you try and remain uniform all through, so that you can create a adequate coverage of the wound all around. फिर से दे दीजिए विस्को, मिथाइल सेलुलोज ही दे दो. लाइए नीडल फिर से. Can you hear me in the audience?
Hello. Is it audible there?
Yes, we can see everything, and we are able to hear sir's every conversation. So he is moving in a very nice way. Now we could see that there is some iris prolapse for the floppy iris, but yet sir is very elegantly and gently managing the things and doing very good round capsulorhexis. And the case appears to be little harder, brown cataract.
Yes, it is a brown cataract. Yes. Okay, so the rhexis is completed now. We'll start with the hydrodissection. So in the hydrodissection, the important thing, especially with the floppy, can I have a finer, less 23 gauge, 24 gauge for hydro? चलिए दे दीजिए फिर. Because it's a floppy iris, we would like a low flow. Okay, this is fine. So important thing is not to inject too much. So we'll inject just a little, and then once the wave has traveled behind, push it so that the wave circulates around rather than coming out on its own. So every time we'll use a small wave and do it at 2-3 points to get a good hydrodissection. And then a hydrodelineation by going till you face a stiff resistance of the nucleus, and then injecting in that plane. Now we have a little iris tendency to come out, which we will counter. So since this is a hard cataract, it may be good to use a little bit of chondroitin sulfate combined thing, so viscoat de dijiye, because it is a viscoelastic with properties that will allow it to stick to the stay close to the endothelium and protect our endothelium. So the next is to ensure that the mobilization has been done. So we will just confirm that the nucleus is mobilized. Like ab de dijiye mujhe trenching ke parameters de dijiye. So we'll do a stop and chop. Here we'll ensure that we create a good deep trench. Chopper de dijiye. A sharp chopper is helpful, but we will first start with the trench. Now there are certain important, इसका थोड़ा tip कम exposed है, थोड़ी ज़्यादा expose कर दीजिए, और वो दोनों side ports जो हैं वो right angle पे. So the important thing is that our tips should be reasonably exposed, particularly in hard cataracts, and our flow of the sleeve should be perpendicular to the main port. We'll start with first clearing the initial epinuclear material in front of the nucleus, and then start with our trenching. In hard cataracts, it is important to increase the width of the trench so that you can get to the depth. Grade 2, ये grade 3 थोड़ा कर दो, वो उसका जो है ना parameters trenching के. So when you want to get deeper, your width needs to increase. थोड़ा मिथाइल सेलुलोज डाल देंगे कॉर्निया पे. Yeah, now you can see the depth of the trench very well. What we can do is, if you want to rotate it 180 degrees and then go on with the trenching in a harder cataract, you can do that so that you'll get a larger length of the trench, and increase it till you feel you have gone through about 80% and start getting some glow. Then important thing in division is to make sure both your instrument go deep before you divide. You can see the divide that has been created. Then you extend it gradually so that you are not using too much force, which is particularly important in a hard cataract. So now we'll go to the other side and then again create the divide. You can see the divide has come up to this point, but again go to the depth so as to avoid too much stress on the zonules in harder cataracts. Now we have the trench all through. कॉर्निया पे मिथाइल सेलुलोज और डाल देंगे. And now we will start chopping parameters दे दीजिए. But we will, so this is a really hard cataract, grade 4 type cataract. What we will do is divide each of these halves into 4 different pieces so that they are reasonable enough for. Now first we'll start with the first quarter. Important thing is to go deep and make sure that you have created a complete chop. But even if it remains attached in the center, you should not use too much force, because that you can even detach later. Don't use so much force that you'll cause in a harder cataracts the zonules to be broken. So here again we are going deeper gradually till we have broken the fibers, managed to do a complete chop. Now the important thing that you do with stop and chop is you also do a debulking of the central nucleus, which is the hardest nucleus. So that is an advantage that you get in these cases. It was initially described in this way, that you can do a little debulking. We'll do a fifth piece also. So important thing in chopping is that you must have a good hold, and then you must use your chopper to go back posteriorly towards the posterior pole of the eye. Then you get the right kind of force to divide. Now we'll rotate it further and go to the other side. Now the chopper is just to the left of the grade 3 पे ही है ना ये chopping parameters ठीक है. So just to the left of where you've held, a good hold is important, and that is where a machine like Centurion is very helpful with high vacuums that are possible. Again, a division of the first fragment. It's not been completed to the center, but we'll not bother about it at this stage. Even if some pieces the division is complete. थोड़ा hold कम है, grade 4 दे दीजिए चाहे.
Hello?
Yeah.
Yeah, we seem to have some signal problem.
Yeah, there's some signal problem, but just can go ahead. Can go ahead.
Okay.
So again, a good hold is important for chopping, and then a direct backward push in order to get a chop. So we'll now go ahead with picking up the fragments. So you can go to the removal of fragments, quadrants. So important thing here is that when we are removing these fragments, the tip is oblique in this active sentry handpiece. You don't use a Kelman tip. So you can see that two fragments were attached at the base, but when we pick them up, we are able to go to the base and remove that attachment.
Sir, we are seeing is such a wonderful way of teaching that you are actually imparting to everyone, just like book how to go ahead in any cataract and particularly in hard cataract. So, sir, we are really learning a lot from your way of doing this surgery.
Thank you. So even if this is attached at the base, you can see that we've been able to very easily get to the base and remove that fragment. So we are now through with one half. We'll go to the other half now. Rotation towards away from your part will be important. But again, you have to make sure you have enough material available to hold. So now you have this part which has been broken separate. Now this had been partially divided, but now since it is mobilized, now we can easily hold it and divide into a more complete chop. So these are leathery fibers because it's a grade 4 cataract, but we can, now that it is mobilized, we are better able to chop it and go deeper. And do a more complete division. Again, the base is attached, but we will not bother about it. This last piece again, we'll hold it closer to the end because our chopper needs to be to the left of the main fragment held where we are holding and then divide again. So now we have these 5 fragments of this half. So we'll start picking up now. Quadrant पे कर दीजिए parameters. Grade 3 के कर दीजिए. Again, it is important to hold the pieces from their peripheral end where it is bulkier. bring it to the center, use the energy in the center, but away from pupillary area. The good part about Centurion is that it brings the pieces to you. But you should do it in a controlled way, not let the fragments float in the anterior chamber. So we've completed the nucleus now, but we'll make sure that there are no fragments sticking close to our side port, which often happens in hard cataracts. Light में देखिए, bulb की तरफ देखिए. So use of chondroitin sulfate helps in ensuring that endothelium is safer. मुझे पहले मिथाइल सेलुलोज दे दीजिए. So this patient's corneal visibility is comparatively less. She's an older patient. She has a large arcus. She has a small anterior segment, so visibility is not as clear. So maybe you're not getting as good a glow.
No, sir. We are seeing it so beautifully, and we could appreciate each and every steps in the meticulousness, with lot of meticulousness followed by you and teaching at each and every step, sir. So,
Thank you.
Yeah.
इसको थोड़ा सा कम एक्सपोजर दे दें टिप का ना, इसमें आईए में थोड़ा सा उसके पास ले जाएं. So in IA, the sleeve needs to be only a little behind, just about the size of the IA opening. The IA opening here is only about 0.3 that we normally use. 0.2 and 0.5 were earlier used, but it was realized that 3 offers the best balance of being able to occlude as well as take in big pieces. So since I'm used to coaxial, I'll start with coaxial, and I'll start with the subincisional first, because so air bubble, ऊपर से wash कर दीजिए air bubble. Subincisional is easiest to take in the beginning, because at this stage I'm used to a straight tip, so there may be a little difficulty, because at this stage the chamber is formed both with cortex and the viscoelastic. So holding that stage I was holding the zonule, so the peripheral part of the capsule which might pull the zonule, so you have to release it immediately when you see any capsular folds. Take care of all the debris. Polish पे दे दीजिए. So any debris, again, when you hold the capsule, you have to immediately release it so that you don't break the zonules and get rid of all the debris. मुझे थोड़ा मिथाइल सेलुलोज दे देंगे? So before removing, I'm putting in some methyl cellulose, because if we have pulled any zonules, they'll be stabilized before I come out. ले लीजिए. Now we'll place our lens. Now to ensure that you don't get a prolapse, make sure that you don't overfill the anterior chamber. Don't put too much in the bag. Just put enough, and then put a little viscoelastic at just behind the wound to keep the iris from prolapsing out. दे दीजिए अब lens.
Sir, it's very good surgery of leathery cataract of this type. Sir, one thing I want to know, sir. Actually, IOP you are using 55, 58. Nowadays, usually talking about the physiological IOP or low IOP.
Yeah.
So, you always use this IOP, or because in this case is 26 diopter IOL power?
No, I use at times in the myopes particularly we reduce it significantly, but in the usual ones generally about 45, 50 is what we use. 48 is what we use. And the myopes we reduce all the parameters, because in myopes you don't want too much fluctuation, too much deepening. Similarly for those cases which have had a VR surgery, I prefer to use the lower parameters of intraocular pressure.
Okay.
So now we are going to do a wound assisted placement of the IOL. Now we don't need wound assisted, it seems. So the important thing is that the lens goes in very easily, smoothly. Then you can, since this is a small eye, methyl cellulose de dijiye, we've not tucked it in, we will dial it in. In small eyes, you don't want to push it too much. As you can see, this lens appears a little too large for this eye. मुझे वो दे दीजिए dialer. So important thing is that once your the distal haptics has gone into the bag, then normally I just tuck it in, so it is a single step procedure, but here I'm preferring to rotate, dial it in. So this is being dialed in. So the lens, the haptic has gone into the bag now. And we'll do a little washing of the viscoelastic before we try and position the lens in the right position. So again, first from in front of the lens, then also a little bit behind. So I go behind the lens, hold the lens with the other instrument, side port instrument, and then make sure that I remove the viscoelastic from the back also, which is important in all cases to prevent the rise of intraocular pressure and all the toxins, all the material that you may have used during your surgery, so that chances of TAS is also reduced. And after you have done enough aspiration from behind, you place the lens in the bag and then try and get it into the axis that you want. Now I'm looking for the position of the marks and I will rotate it. आपके पास दूसरा वाला डायलर है, वो जो डम्बल शेप में होता है, उसको बोलते हैं
वाइड डायलर दे दीजिए. वाइड
वही नहीं, वो एक जो क्रूगलर है, हाँ क्रूगलर दे दो. क्रूगलर, ओके.
So Ashok sir, you are almost done with this case.
Yeah.
So as Dr. D. Ramamurthy sir has to catch a flight, can we go ahead with this presentation and then when you come for the second case, we'll have discussion again?
Absolutely.
Okay.
Okay, bye-bye.
Thank you, sir.
Yeah. अच्छा, अब जो है इसकी अलाइनमेंट के लिए मुझे थोड़ा और मैं पोजीशन ले आता हूँ, फिर आप मुझे, मैं दोनों परकिंजी इमेजेस को अलाइन करके फिर दे देता हूँ आपको. कौन यहाँ वेट करो, अब परकिंजी इमेजेस एनालाइज्ड हैं, अब मुझे वो ओवरले दे दो तो सेंटर कर लेता. 4 degrees is there, okay. A little more. के कॉर्निया वेट करिए, वो परकिंजे इमेजेस न्यूट्रलाइज कर सकूं।
Sonali, you can go ahead introducing
चलो अब 4
Ramamurthy
डिग्रीज
sir.
पे अलाइंड है।
I invite Dr. D. Ramamurthy sir to please go ahead with his presentation.
Very good afternoon, and thank you all so very much for staying back. And sincere thanks to Dr. Subhash Prasad, this team, and at Divyadrishti for this wonderful opportunity to interact with each and every one of you. I'll be covering on these optimizing outcomes in modern cataract surgery. I think the current standards of cataract outcomes have changed in the last 5 to 7 years. Nowadays, we are not talking about uncorrected visual acuity for distance alone, but for all distances, distance near and intermediate. This gives us an excellent opportunity to give back the patient the quality of vision that he or she had at the age of 20 years, when each person is supposed to have the best quality of vision. And we are also concerned about immediate restoration of vision. And since we are operating on early cataracts, patients who are going to live 3-4 decades after the surgery, what we do today might long outlive our own professional lifetime. So essentially, it has to subsist the patient for the rest of their life. So essentially, cataract surgery is not just a question of removing an opacity and putting in a clear lens nowadays, but it's not vision enhancing and not just restorative. So what are the 5 factors I think determine success in cataract surgery? It's, as you all know, the patient's age. Younger the patient, they are supposed to adapt or get neuroadapted more easily. But having said that, their expectations are a little higher. Lifestyle and psychological profile, we have all discussed this multiple times. Type A personalities are a little more difficult to satisfy. Comorbidities, especially those which can have an impact on the contrast, like corneal abnormalities, keratoconus, post-refractive surgery scenario, a patient who has early glaucoma or age-related macular degeneration, obviously they need to be handled differently. As far as pupil size itself is concerned, it's between 2 millimeters to 5 millimeter ambient pupillary size, which is supposed to be most optimal as far as quality of outcomes is concerned. If it's less than 2 millimeters, it's diffraction, which deteriorates the quality of vision. Well, it's more 5 millimeters, then the patients tend to have to handle a little more of spherical aberration than normally. And understanding, we have so many hundreds of different eye intraocular lenses available today, some of them even from the Indian manufacturers. You have to essentially focus on a few intraocular lenses which you are going to use in your practice, and then become very familiar with their usage. And the most important factor as far as uptake of intraocular lenses by our patients, I feel, is the confidence with which we as surgeons educate them about the benefits of, recommend to them the type of intraocular lens they need. And it's your attitude, knowledge and experience which is most important. I think biometry is as important as the intraocular lens implantation per se. And for me, it's been the Barrett-Suter formula which we resort to. And as I will explain, it's not even the Barrett Universal 2 formula, but the Barrett toric calculator which we most often use. Why exactly we are using the Barrett formula normally? It's because, as we all know, the posterior corneal astigmatism, which is most often against the rule, is automatically incorporated in the Barrett formula. And there is a drift of astigmatism in the posterior cornea from with the rule to against the rule at the rate of 0.3 diopters every 10 years of the lifetime of the patient. This is again incorporated in the formula, and it usually targets about 0.25 diopters of with the rule astigmatism. And there is also, it takes into consideration the principal plane of the intraocular lens, because of it the toricity ratio is also taken into consideration. That is a plus 10 diopter base power of the lens at a plus 30 diopter base power does not need the same toricity, and that's something that's incorporated. The induced astigmatism, for a long time I used to believe that my temporal clear corneal incision induces about 0.4 diopters of astigmatism. Now we know that it has both a direction and a magnitude, and a 2.4 millimeter clear corneal incision just creates less than a point at 1 diopter of astigmatism. So as I said earlier, as you can see in this particular case, there is just about 0.7 diopters of astigmatism, but what is recommended is a T3 or a T4 intraocular lens. So oftentimes I am asked that what is your cutoff as far as toric intraocular lens implantation is concerned. So basically what we do is to feed the data into the biometer, and depending on what it tells you, whether the patient needs a toric lens or not, we essentially choose this lens. So against the rule astigmatism and with the rule astigmatism are two completely different animals, and this is something that need to be understood by all of us. And where exactly are these formulae available? Of course, many of these latest optical biometers have this. But just in case you do not have access to this, then the ACRS, APACRS websites, also you can use them. And if you do a good immersion A scan and a laser the results can be as good as a laser interferometry. Basically, the advantage of the optical biometer is that it's idiot proof in the sense that it does not vary too much depending upon the expertise of the particular surgeon. But then if you are competently doing immersion A scan using autokeratometry readings, then you can go to these websites like the ACRS and APSRS. Right in the opening page, there is an IOL formula. You can click on it and use the appropriate formula to get a good clinical outcome. I am not usually bothered very much about high-end textile tycoons or politicians. Most often they do not complain once the surgery is done reasonably well. But a lady like this, who if in case she is unhappy, in spite of the fact that everything has gone well, is going to go around telling the whole colony that she is not quite happy with the surgery. And this can sometimes because of the ocular surface being inappropriate, but just not post-operatively, but right through the surgical procedure, pre-operatively, intraoperatively, post-operatively, taking care of the ocular surface is extremely important. Even before doing an optical biometry, optimizing the ocular surface would be a good idea. When the patient complains of post-operatively dryness, burning, fluctuating vision, photophobia, increased mucous matter, etc., then it's often an ocular surface which is at fault and it needs to be addressed. So all these are the different ways in which you can pre-operatively optimize the ocular surface and post-operatively treat it. But we are all familiar with it, and I'm not going to go into the details. But the most important point that I want to leave behind is that as far as the post-operative medication is concerned, less is more. Like you can see here, what I normally use is dexamethasone moxifloxacin combination just for a period of 2 weeks, and then NSAID drops for just twice a day for 6 weeks, and a lot of lubricants preservative free for a period of 6 weeks. At the end of 6 weeks is when I have my final checkup. Nowadays, I've asked them to start using them, these lubricant drops for 4 more weeks. I find that with this regimen, the patient's complaints of discomfort, irritation, dry eye symptoms, etc., has completely considerably come down. We are also aware that when you have a multifocal intraocular lens in place, in case there is even a diaphanous thickening or a wrinkling of the PCO, it can cause a drop in the quality of vision, not just alone in the quantity of vision. And doing a YAG capsulotomy, usually 3 to 6 months after the primary implantation of the lens, does take care of this problem quite adequately. You can see both these patients. This is a fellow eyes of the same patient. You can see this piece is crystal clear, where there is a little bit of wrinkling because there is a small rexus runoff over here. So even this can cause a deterioration of the quality of vision, and this needs to be taken care of. I think all of us are aware, and most of us have shifted on to using an OCT as a part of a preoperative workup, because anterior segment surgeon doing a quick retinal examination can often miss some of these problems which can be coexistent, which is not causing a real drop in the quality of the visual acuity, but because they all deteriorate the quality of vision and contrast sensitivity, they may not be ideal candidates for a premium intraocular lens implantation. Something that we do not often concentrate on is a centration of the intraocular lens. Especially if you have a diffractive multifocal intraocular lens, you can make out when the lens is decentered. Again, fellow eyes are the 2 patients whom I had operated. This eye obviously is very well centered, but as you can see, this is somewhat decentered. And this decentration is because of, this could be because of large angle kappa, but sometimes it could be also because of excess runoff. But as you can see in this case, this was because one of the haptics was in the sulcus. And once you have, whenever you find that a diffractive lens is not well centered, there is something wrong. And this patient was actually taken up post-operatively, and all we have to do is a diffractive multifocal toric lens and a panoptic toric. And as you can see over here, just once you introduce the entire lens into the capsular bag, then the centration of the lens becomes much better. And this is something you need to focus on to derive the maximum outcomes from these lenses. And this is the preoperative re-rotation, and after the rotation you can see the centration of the lens, and this is something that we need to concentrate on. Another aspect is the corneal topography, which we routinely do. It is to ensure that the astigmatism that we are trying to correct on the with our intraocular lens corresponds to the anterior cornea, and in case there is too much of higher order aberrations, then the patient might be less than optimal candidate for a for a premium intraocular lens. An eye trace is not a prerequisite for adapting premium lenses in your practice, but you can see this is the aberrations from the internal optics or from the lens. This is from the cornea, and this is from the total eye. As you can see, almost the entire aberrations in this particular eye seems to be from the internal optics, that is from the lens, which is going to be removed when you do a cataract surgery, while the cornea itself seems to be pristine. So such a patient is an ideal candidate for getting a toric or a multifocal toric lens, and obviously would get the best of outcomes. And again, angle kappa, angle alpha has been often talked about. When we talk about an intraocular lens implantation, is the distance between the visual axis and the optical axis, which is most important. And it is said that anything beyond 0.5 millimeters is a relative contraindication. But nowadays that view is going away, and even up to 0.7 millimeters, we go ahead and implant these lenses, provided all other things are quite normal, and then the results are quite optimal. And whenever you have a multifocal intraocular lens, it's extremely important that even small degrees of cylinder is taken care of. And so toric multifocals is the way to go, and that's the reason I said that Barrett toric calculator is the primary formula that we use, and just in case there is even a certain amount of cylinder that needs to be corrected and the patient is opting for a multifocal intraocular lens, we go ahead and use this. You might think that all these things are prerequisites as far as premium intraocular lens implantation is concerned. That's using an optical biometry, topographer, aberrometry, high-end phaco machines, LRCS, advanced microscope, digital imaging during surgery, etc. Obviously, if you are doing a prelex case or routinely doing high-end surgeries, it's a good idea to invest in at least some of these machines, but you need not really wait for getting all this equipment before you start doing premium intraocular lenses. I think a well-done, repeatable immersion A scan, standardized autokeratometry, which a experienced optometrist or a biometrist or the surgeon himself does, along with the usage of standard formula, would often give you good results. Usage of good phaco techniques with predictive refractive outcomes, always keeping in mind that the corneal astigmatism has to be taken care of, gives you excellent outcomes over and over again. As far as residual sphere and cylinder itself is concerned, I think prevention is the best approach, and you can often do that when you are doing your biometry properly. But just in case you have a residual refractive error, make sure that the patient actually requires treatment for it. Oftentimes I have patients who are coming to the hospital feeling quite happy with the outcome, but the optometrist makes them sit on the lane, spends quite some time with them, and makes them understand that the last line is not so very clear. So really it's not really necessary. If the patient is 20 happy, leave it alone and don't necessarily go after those small residual powers which need not be addressed. But just in case the patient is complaining, then look deeply into what exactly is the causation for the suboptimal outcome, and then you go ahead and address it. One of the ways that you can do it, and we do it free of cost, and often the patients are pre-warned that in case there's a residual error, a transepithelial PRK would be necessary. And this is, you can see, an intraocular lens is there. 3 to 6 months after the primary surgery, if there is a residual error, we go ahead and take care of it using a laser vision correction. And it not only takes care of the residual error, But even if the patient has some symptoms of dysphotopsia, that is something that significantly subsides once you do the correction of the residual refractive error. Invariably, mitomycin C is also applied irrespective of the amount of refractive error that needs to be corrected. And in case there is a large residual error, like in this case which received a intraocular lens, monofocal lens, it is a post laser vision correction, has a +6 diopter residual error, was actually referred to us. The primary surgeon had even done a yak capsulotomy, and you can't correct a +6 diopters on the cornea, and at the same time, because it's a hydrophobic acrylic lens which has remained there for a long time, it's difficult to exchange this lens also. So essentially what we do is to implant a piggyback lens. The simple formula being that for every 1 diopter of hyperopia, you need 1.5 diopters of correction, and for every 1 diopter of myopia, you need 1 diopter of myopic correction. So it's a +6 diopter residual error, and what it goes in is a sulcoflex lens of +9 diopters. Almost immediately the patient gets a good outcome, and you also have piggyback lenses with ability to correct toricity, multifocality available today, and these are essential tools for correcting residual errors. You can see after the piggyback placement in the anterior segment OCT and the slit lamp, you can see the primary lens and the secondary lens. The secondary lens is always placed in the sulcus while the primary lens is in the back. Just in the limbal relaxing incision is also a good way to go. Can be used in any clinic, and it's done at the limbus, and essentially you have good Nickman nomograms, etc., which tells you the arc length of the incision that you need to make. All you need is a diamond knife which is unguarded with a guard at 600 microns, and it's a simple procedure. Debulks the amount of astigmatism that the patient has to deal with, though it's not refractive accuracy. This is what you see on the first post-operative day. You can see the limbal relaxing incision. This has been used along with the cataract, primary cataract surgery. Laser arcuate keratotomy is again something that we do along with the cataract surgery. And as you can see here, that in case it's a small amount of astigmatism, 0.5, 0.75 diopters, very often the nomograms are available in the laser machines itself, or in machines like the Varion, where the length of the arcuate incision which needs to be done is provided to you. And in case the astigmatism is not significant enough for a toric intraocular lens, you can combine it and open up this incision on the table itself. Just in case you have a suboptimal outcome after toric intraocular lens repositioning, implantation, you have to see what is the amount of residual error. As far as the residual error is the spherical equivalent is almost 0, then rotation of these lenses is going to help. What exactly do I mean by that? If it's a -1 with +2 diopters of astigmatism, that means the spherical error and the astigmatic equivalent of the astigmatic error is almost cancelling it out each other, and rotation of the lens will help. Because when you are rotating lens, you are not introducing any spherical or cylindrical power, but you are just redistributing it. For example, in this case, because the spherical equivalent of the residual error was almost 0, and as you can see, the toric lenses are not aligned in the proper axis, all I do is to go in with a irrigation spatula cannula and then gently rotate the lens into position so that the toricity alignment is restored, and that sort of takes care of this patient quite adequately. So it's important that when you use expensive technology like this, you also strive to get the optimal outcomes, and sometimes a couple of minutes procedure would help you to achieve that. As I wind up, just a few quick case scenarios. A preoperative IOL master, what it showed me was just a 0.87 diopter. Some believe that even up to 0.75, 1 diopter, a toric intraocular lens is not needed. This was in the year 2019 when the Panoptix lenses were just coming in. We did not still have the toric version, and as you can see over here, I decided to just go ahead and implant a Panoptix trifocal in this patient. Got an excellent visual acuity as far as near vision is concerned, almost read N6, but had only a 618 visual acuity as far as distance vision is concerned. Had a significant amount of mixed astigmatism, was not quite happy. We said that at the end of 3 months, we'll go ahead and do a laser vision correction for you. Patient was quite perceptive, understanding, so he said that while waiting, he'll get the other eye operated. Almost a similar situation. and 0.86 diopters of astigmatism at 180. But what we implanted, because the toric panoptics had become available, was a panoptics toric lens of T3. And what you see over here is that the patient in the eye which received a panoptics toric had an excellent outcome of 6.6 and N6 for both for distance and reading. Actually, the patient was quite happy, bilaterally implanted, chose not to undergo the laser vision correction. So this emphasizes the importance of dealing with even small amounts of toricity, especially if you're implanting a toric multifocal lens. And case 2 over here, as you can see here, 0.98 diopters at 170. And what the Barrett toric calculator shows me is that what the patient needs is a T4. But if it's a with the rule astigmatism, even a 0.75, what is required is a non-toric. So essentially the point I want to make is that don't just go by the magnitude of astigmatism. The axis of the astigmatism is also equally important. So go by what the Barrett toric calculator tells you and decide whether the patient needs a toric lens or not. As you can, there was a point of time when the Symphony lenses were very much in vogue. We were using them in good numbers. A significant astigmatism, that was a very good lens also, but it was a more a EDOF lens, not adequate for near vision. We implanted a toric multifocal lens, a toric Symphony in this case, but the patient essentially had good distance visual acuity, but as you can see here, required a +1 diopter as far as near vision is concerned. So when he came for the second eye, what we essentially did was to go ahead and put a toric panoptics, which because of its trifocality gives us excellent near vision also. So bilaterally implanted, you can see that the patient acquired good near vision correction also. So mixing and maxing of lenses is also a great way to go to optimize outcomes when we deal with these patients. And neuroadaptation is something that we need to always keep in mind, encourage our patients also about it. It can take place even from 3 months to 1 year. Whenever the patient has problems with dysphotopsia, especially in the initial periods, encouraging them, telling them this is going to subside, asking them to use their eyes for all their usual activities, whether it's for driving or for watching TV or reading or working on computers, often helps them to neuroadapt, and less than 4% of the patients actually stay with the problem and continue to complain. So I think the most important message as far as getting optimal outcomes in modern day cataract surgery is counseling, and it's done both preoperatively and postoperatively. Whenever we are talking about premium lenses, we are not talking about terms about you throw away your glasses, discard your glasses also, etc. We are always telling them this is going to lessen your dependence on glasses. Bilaterally implanted, most often you can do most things without glasses. Always forewarn them about dysphotopsia. Encourage them, don't scare them away because of it, and encourage them by telling that it's going to subside over time, but initially you might have to contend with it. Always encourage bilateral surgery, because once the visual cortex gets similar impulses from both the eyes, better are the results. You can tell them that a touch-up procedure, which is done usually free of cost, like a laser vision correction, might be necessary. And neural adaptation is something both the patient, the physician has to patient enough, and usually it helps us to solve whatever initial problems these patients might have. Thank you so much for your kind attention.
Thank you so much, sir. I suppose there would have been a lot of questions, but since you have to catch the flight, and it was very elaborative talk, and always one of the, I think, talk which is liked by everyone and very relevant these days also, because most of the patient times, even if you are 100% correct or accurate, patients sometimes are not happy, and there may be these things which can actually cause unhappy patients. So very useful tips given by you. Thank you so much, and thank you so much for coming here. So can we shift to OT now?
Sir, can I ask one question, just one question? Sir, the piggyback lenses which are used, is the risk of recurrent iritis more with such cases? Because normally single piece lenses we are said not to put inside the sulcus.
Yeah, I mean it's a very good relevant question. This one thing is it's made up of hydrophilic acrylic material, and I have used quite a few of them for negative dysphotopsia, for correcting residual errors, etc. And what we find is that these are slightly larger lenses also with undulating haptics. and usually it's not a problem. I do keep them on, usually I used to make a small iridotomy also and put these patients on steroid drops for a reasonable length of time, but it has not been a persistent problem, at least in my hands. Concerns about CME is also there, but usually it's not a case.
So sir, if there is a PCR, so can we put a single piece lens in the sulcus? Normally it is avoided, but
you know, that's something I mentioned during when I had the complication during my life surgery. There have been instances when, you know, nowadays the problem is no multifocal intraocular lens or toric lens comes as in the three-piece platform. All of them are available only in the single-piece platform. To the extent possible, we always place these lenses inside the bag. But there has been occasions when there's been a small, the other eye is already having a multifocal lens, and then I have created an optic capture or a reverse optic capture and placed these lenses in the sulcus. Again, this is not the ideal way to do the surgery, but then I have found that with sufficient hand holding, these patients do well over time. It's not a large experience of placing these lenses, but once in a while we have to resort to this because our uptake of torics and multifocals is increasing.
Thank you. Thank you.
Thank you so much, sir.
Thank you.
That was a very nice talk. Now Dr. A.K. Grover sir is in the OT and he'll be starting the case on cataract.
So we are starting.
Can we have the case details from OT?
Yeah. So we are starting ahead with the next case. The patient is a 58-year female who presented with dimness of vision. Right eye vision is 6/9. K1 is 42.80 at 27 degrees. K2 is 43.30 at 117 degrees. Astigmatism is minus 0.77 at 23. Total K is minus 0.50 at 27. Axial length is 23.27 millimeters. So we are going ahead with a Clarion VVT IOL of 22.50 diopters.
Can you hear me now?
Is the sir's voice audible?
Can you hear me now?
Yes, sir. Yes, sir. Very well.
Okay. So thank you, Dr. Ramamurthy, for that wonderful talk. Really enjoyed it. So we're now starting. We'll start with a marking of incision near limbal, absolutely close to the limbus, 2.2 millimeters. Make our side port at approximately 1.5 clock hours. Pressurize the anterior chamber to get a good section. 2.2. So with a 2.2, we'll make a tunnel of about, by staying intrastromal. So this direction will be along the dome of the cornea for 1.5 millimeters, then turn in the iris parallel plane and come back with a little extension of about 0.1 millimeters. And then we displace the aqueous by going to the distal end so that you don't have any waves in the anterior chamber when you're doing a rhexis. आपको light की तरफ ही देखना है. So we will start our capsulorhexis. Try and be central, and then a horizontal incision of 1.5, lifting it up to make it 2.5, and then continuing with the rhexis. Try and keep it about 5 millimeters so that you have a surrounding of about 0.5 millimeter on all sides when you put in your 6 millimeter optics. So ending from outside in, because that is important if you want to prevent extensions. Hydro, thin cannula. Now here again we are going to go just under the the capsule, lift it up, cortical leaving dissection as defined by Howard Fine. Then inject. Let the wave travel, but don't let it go all over. Just stay in the back, at the back. and push it so that it moves forward. So 2 or 3 points are enough, and then you push it back, and then your delineation till you get the golden reflex. Inject again and make sure you create that buffer for your endothelium. Then just enough mobilization, just about, to check that the mobilization has happened. Chopper. ये दे दीजिए. Okay, now we'll start with the sculpting. I prefer this stop and chop for the reason that I feel it gives you a much more uniform 2 pieces and a very controlled surgery. So generally a couple of passes are all that you need in a moderate cataract like this, and then you can go to that depth and divide the nucleus into 2 fragments. You don't use much more energy than you do with a direct chop. And then chopping के parameters, so you embed it and then backward pressure gives it a chop. So here 3 fragments will be enough, because it's not a hard cataract. So these 3 pieces, and then we go to the opposite side. So where you have buried the, embedded the tip, just to the left of that I would go directly backwards till I see the chop and then separate. So now I have the 6 fragments. अब वो दे दीजिए parameters, fragment. So quadrants removal, yeah. So bring pieces one by one in a controlled fashion. Now the tip is, this active sentry handpiece, the tip is kept oblique, not anteriorly. You pick up the pieces one by one, because all the pieces will come on their own because the fluidics is so good. But don't let them move forward, because then you tend to get more stride. So pick up the pieces one by one. Bring them to the center, stay in the pupillary plane. The fluidics is so good that you will have a very well formed chamber. Epinucleus has already been cleared, so this is all that we need to do.
Excellent demonstration of all the rexes and then fragment. Thank you so much, sir, for teaching step by step to all of us.
Thank you, thank you. Subincisional, again I'll use a coaxial, because that's what, when we learnt our Phacos, that was in the year 94, 95, these bimanual had not become available. So we started with coaxial and we've stayed with coaxial because it's quite fast, and except for an occasional difficulty with subincisional cortex, most of the time we are able to handle them well. So there is a small fragment of nucleus left, we will just crush it and take it. Small bits of cortex all around which we will take. फिर polishing दे दीजिए. Polish for these debris that are visible. We'll slowly pick them. Full weight, अच्छा नहीं ठीक है आ गया. So once those debris are done, we'll come back. Methyl cellulose दीजिए. Lens. So the advantage with lenses which open very gradually, like the Clarion and all the lenses based on Clarion platform, that you can easily place them in the bag. They open very slowly. You can very easily tuck the trailing haptics in. So again, a wound assisted. So you have the side port giving a little support. So we go in and we have the trailing haptic also go in very easily like this. So already the lens is in the bag. Hydration. IA. So as you can see, the lens is in the bag. We'll then clear the viscoelastic from in front and from behind. For methyl cellulose, we need to do a good thorough removal of the viscoelastic, because unlike viscoelastic like Helon, which comes off in a bolus, this dispersive viscoelastic, unlike a cohesive viscoelastic, will come out very gradually. So we'll stay behind and make sure we remove all the bit of methyl cellulose from behind. And then make sure that the lens centers well again. You can see this change of the central optics which you have in the Vivity lens. That central zone which gives us the extended depth of focus. And I spoke about the Vivity lens in my talk. So first we make sure that the iris goes back, and then hydration is by going perpendicular to the wound edge, so that you're not pushing too much fluid into the chamber at this time, but at the edges of the wound, so that it hydrates well and thereby seals it well.
Sir, one thing, usually nowadays some surgeons not doing main port hydration.
Yes.
Only side port, even someone using only one side port. What is your view, sir?
Yeah, that is a choice that some people have. They feel they are causing less distortion to the wound by that. It's an individual choice. I don't think it matters. Many people are now doing avoiding a visco insertion. They would insert their lenses under the air. So those are all individual choices, whatever one is more comfortable.
But hydration is more safer side, hydrating the all three wound. It is not more safer than hydrating a single wound or two wound.
I don't normally hydrate the side port. I would only do it for the main port normally. I use a 15-degree knife for the side ports, and it's a really beveled incision, and it doesn't need any hydration. So in the end, the important thing is to make sure that the chamber is deeply formed, the intraocular pressure is moderate, not too high. So this is the last step which I always do, to make sure that the wound is stable and pressure is not low. Now right now I think there is a little leak, because I can see the movement of the particles towards the wound. So which implies there is a little more hydration of the wound that I would like to do. So the end point is that nothing in the chamber should be moving. The AC should be well formed, and the pressure should be just about moderate. It should not be.
This is a good point. Good point, sir. Thank you, sir.
Pressure, if it is too high, then you could cause a vascular occlusion. So make sure that it's formed. There is no movement of the particles towards the chamber. Now this is hard, so which is a good indication that sealing is adequate. But I need to lower the pressure a little before I finish. Still not happy, a little more lowering.
One more opinion, sir. Putting the IOL under BSS. What is your view, sir?
It's a very good. It's a very good technique, but it takes a little getting used to. It's not difficult at all, but it avoids all the hard work of removing the viscoelastic, saves time, probably gives less reaction. So a lot of people are using it, and once you're used to it, it is a very good technique.
Also helpful with the toric cases, more helpful in toric cases.
Yeah, because again, you would like to ensure in toric cases that all the methyl cellulose from behind is well removed. Stability of the lens has been shown to be related to a good viscoelastic removal. So particularly in toric cases, what you would do is make sure you have first aligned the Purkinje images of the lens and cornea, ensured centration, ensured the axis, and then finally push the lens a little back towards the bag. Before that, make sure that you've removed all the viscoelastic. So all those steps are important in ensuring that your toric lens remains in position. And it has been seen that the maximum movement takes place maybe in the first half an hour. So some people would say that having less movement of the eye, putting a pad for a short time in these cases may be a good idea, particularly in myopic eyes, in eyes with unstable zonules like post-traumatic ones. Those with vertical axis lenses have been shown to rotate more. So all those points are important in ensuring a stability of the lens besides a good design of the lens. Those lenses that are designed to be stable, like the C optics, the C haptics that we have today, they are all good stable lenses generally.
Sir, can you talk?
Grover sir,
come here, sir.
Grover sir,
yes.
We have observed 2 cases operated by you. In previous case, the pupil size was compromised, the AC was shallow, and the nucleus was, I think, grade 4+.
Yeah.
But we did not see any difference in your comfort. You were comfortably doing that case also and this case also. Is this a God gift, or you have adapted this thing?
I think 2 things that you gradually learn in life to be more calm and more relaxed. A little bit of yoga, pranayam or meditation helps, certainly. And then of course, second is comes with having done a few cases earlier of hard cases, having done a few live surgeries earlier, because live surgery is additional anxiety, additional adrenaline. So if you've done a few, it helps. So gray hair probably help a little.
Sir, I had one question.
So one message from your surgery is go slow, give some time, don't be in hurry. Yeah,
yes.
That is also.
Yeah, particularly in teaching exercises.
Yes.
They are normally faster.
Thank you.
But,
sir, I had one question. In monofocal patients, when we are doing post-operatively, when we need to do YAG capsulotomy for PCO, generally we try to make only adequate opening. But when you have these trifocal lenses, when you have these EDOF lenses, you are also worried about the stability and centricity of the IOL.
Yeah.
So what is your advice about the YAG size opening?
Particularly those lenses where there is a zone, you have to make sure that you reach the peripheral zone as well. So that optical part has to be taken care of. In addition to stability, I think, except for high myopes, I won't worry too much about this. I've never seen stability compromised by a 4mm capsulotomy.
And then the issue of glare and other issues which come with trifocal post-YAG capsulotomy.
So if you make nice smooth edges and go beyond uniformly, there you have a guidance of where to center it, because your center of the lens is seen. You have those zones to guide you. So those help you in making sure that you do it centrally and that you do it concentrically till the point where you have ensured that you go to the peripheral zones also, which are important in lenses.
Thank you so much, sir. Thank you very much.
Thank
take over next
thank
case.
you, Grover, sir. Thank you so much for demonstrating in a bookish manner the way everyone should do and should learn. So that was a great teaching, sir. Thank you.
I think I must thank the wonderful staff. They assisted so well. The instruments were so good. And also the Alcon team and the wonderful equipment that they have given us.
Sir, we always call you teacher of teachers. That's why we call you teacher of teachers. The way you have demonstrated us is marvelous and exemplary, sir.
I think that is very kind of you. It's always
Thank you so
a
much.
joy to be in Patna. Thank you so much.
Thank
Thanks
you.
for the opportunity.
So can we shift to the other OT?
Now, next we have Dr. Vidata who will be operating a retina case, and Dr. Vidata needs no introduction. He was a senior consultant at Chitrakoot, and now he has joined Divyadrishti Eye Center. And can we have a case details from OR?
So the patient is a 56-year male who presented 3 months back with right eye phacomorphic glaucoma. He was operated and left aphakic. Axial length is 23.80 mm. So now we are going ahead with a scleral fixation IL of 18 diopters.
Camera view, please, from the OT.
Hello, am I audible?
From microscope from the OT.
Am I audible?
Yeah, you are audible.
Yes. Very odd. Dr.
So-
Deepak, please help in discussion for this case.
So by now I have done a peritomy and put an infusion cannula here. Now I will be going ahead with the PPV. Peritomy and 2 incision I have placed just opposite, and the tunnel I have made using a crescent blade. Infusion on.
You have made scleral flaps also? No.
Sorry?
You have made scleral flaps for the tunnel?
Yeah, I have made 2
Two
tunnels here
tunnels,
at the opposite here.
Yeah.
So I will be inserting this trocar slightly superiorly so that it doesn't hinder in the fixation of the IOL. This is a non-vitrectomized eye, so it will take some time to do the vitrectomy also.
So you'll be doing a complete vitrectomy
Yeah.
in this case? Okay.
That is my preferred choice, sir.
Okay.
It's better to do complete vitrectomy. When you go inside, finish everything so that the patient doesn't land up with problems.
Absolutely.
I have seen many people making breaks and coming up with retinal detachment.
Yeah, and just doing a limited anterior vitrectomy sometimes may not help.
So just doing an anterior vitrectomy. It's important when you go inside, cut the port side vitreous. As a beginner surgeon, many people land up with the port side breaks. That's it. They're going in.
So again, what are the parameters you are using for your vitrectomy?
For
Can you
Corvette, inverter. For Corvette, I prefer to use it 10K cut rate. I'm yet to use the 20,000 cut, and vacuum I keep at 600.
Okay.
Is it focused?
Yeah, it is focused. We can see.
Thank you.
So there's a complete PVD already there.
Yeah, that makes my job a bit easier.
Yes, yes. So would you want to stain also or not in this case?
Since there is a PVD, I
Yeah,
don't think there is any need for a stain.
staining.
Although I have kept the stain ready, IVTA, but this is not required in this case. I
And I
cut
think-
it in a clockwise, I mean round clockwise manner, so that nothing is left.
And I think the patient is a high myopic patient.
It's 18 diopter.
Yeah, so it's a bit high myopic. Yeah. So what was the vision with plus 10 in this case actually?
It's 6.9, improving to 6.9.
9, okay.
This was actually phacolytic glaucoma patient. I had planned phaco but could not complete it, and then I had to do SICS and remove the whole nucleus. And then I left it like this so that we can plan. And I thought that patient may not get vision, so let us wait, check the vision. And with the 10 plus 10, patient was actually improving to 6.9, and this was healthy, you can see here.
Yeah,
so that's why we went ahead and tried to do.
Yes.
This was our home production of you can say aphakia.
So what was the duration? When did you do the surgery? Like after how many?
So will you indent and do a base dissection also? No. Not
So no sir. I will just check the periphery if there is any breaks.
Yeah.
And we are done with the PPB.
Okay. So no peripheral lesion.
Yeah.
No lattices.
It's
nothing.
important to check this.
Absolutely.
So this case was operated for SFIL, being operated for SFIL after 5 weeks of cataract surgery. Although as suggested, it can be done even immediately on table or later. So
yeah, but
timing.
since it was a phacolytic, I think it's always better to let the inflammation settle down.
So there is no break inside.
Yeah.
We'll proceed with the SFIL. .5 mm. Is it centered?
No,
not
centered.
Now, yeah. Now we can see it's centered.
Yeah.
All right.
But it's
So-
not focused.
Yeah, I will
now
focus.
it's focused.
Yes.
Yes.
Slightly fine focus.
1.5. So I make the port at 1.5 mm.
Dr. Vidhata, I can see there is small amount of picking of the pupil at the your nasal end side,
Yeah,
probably. So I think there is some vitreous here, or is it iris atrophy?
It looks like, I don't think there is vitreous. I can't see it. I will make a port and then I will see. I have already make a port. It's what? One.
So Deepak sir, meanwhile you can discuss what are all the ways of SFIL and what is your
Vedanta,
preferred way.
you are making a flap.
I have already made a flap.
So do you think flaps are necessary to be made, or it can just you can directly go and make the port and exteriorize the haptic and then tuck in the haptic in the chariot tunnel?
Actually, this is my preferred choice. While if you use a MVR, sometimes the flap gets lost. I mean, the hole gets lost, and then it becomes difficult to find the hole. And you can use the MVR.
Or we can also use the trocar itself.
Oh yeah, lens keratome.
We can use the trocar itself to make the opening.
Yeah, but I use trocar only, but here the SFL forceps won't go inside with the hole. So it's a bit thicker. I was using trocar only till now.
Okay. So the forceps is which gauge forceps?
It's I think 23 gauge, I think. The IOL is Oro lab, so I will have to extend a bit. The injector is a bit thicker one.
Okay. So it's around 3.2 because
yeah. SFL forceps. वो बाद में.
So this is basically the chariot technique you are using.
Yeah. The nose of the patient is a bit long, so I'm finding it difficult to go.
Yeah, sometimes So
I will try to catch the haptic.
The leading haptic has to be catched.
And it's important that you hold the tip.
Yeah.
If
The
you don't
tip of the
hold it.
haptic. And this is a MST forceps. So this is very important to hold the tip.
If you don't hold the tip, it will, while pulling it out, it falls down.
Yeah.
This is where every surgeon panics a bit. Yeah, it has come out.
Yeah, it has come out well. So one important step has been done, and we have to make sure it doesn't fall back
Yeah,
inside.
I will put a
yeah.
silicone sleeve.
Very good, yeah.
26 gauge. Usually I keep it inside the forceps only, the sleeve, but it's so this will prevent it from falling back.
Falling back, yes.
Yeah, side put.
So now with the so you're going to use the handshake technique, or
yeah, I will make a side put here.
Yeah.
दोनों दो both है सब file forceps. The nose is very long.
Yeah, it makes manipulation a bit difficult.
Yeah, it's very difficult.
Yeah, so using the handshake technique now, the trailing haptic can be held.
Again, the same.
The tip has to be
held.
Yeah.
It's not focused.
Yeah, now it's focused well. Yeah.
I will tuck it.
Yeah, so congratulations, Dr. Vidhata. Half of the job has been done.
Yes, sir.
The most difficult part has been done.
The most difficult part.
Yeah.
Tooth forceps. The good thing with this, I can lift the flap and tuck it in.
So you have already made the Chariot tunnel?
Yeah.
Okay. So you use the 26 gauge needle to make it, or?
No. I use the crescent blade.
Okay.
Again, it's important to hold the tip here also. Otherwise, it will bend. मुझे वो दो प्लेन हाँ it's tucked in. There is a, I think, I don't know why this is, we'll have to see.
Actually, yeah. So now using the pull and push technique, you can center the lens.
Yeah. So we are done almost. There is a vitreous strand, I think. I will cut it off and we are done almost.
Yeah.
cutter.
So important observation for everyone is that whenever you get peeking pupil, always suspect, particularly in a fake patient, always suspect there may be some vitreous. So it is there, so he's taking care of that. And the most important thing is what Dr. Deepak has mentioned, that it is very difficult to take out the second or trailing haptic actually, and many times when you are operating on the left eye of the patient, if you are right-handed person, you always feel difficulty, particularly if the patient nose is very long like Akhilesh Yadav ji and so.
I think Dr. Subhash mentioned at the beginning itself, he felt there is a...
So it's well centered.
So very good surgery by Dr. Vidata, and congratulations.
Thank you.
And let me say that this is the first live surgery of Dr. Vidata, and it looked so confident. Without any flaw, he could manage it so well, and it was a tricky case. So congratulations, Dr. Vidata.
Thank you, sir.
So
we are done.
And we have his proud father here also, watching, performing him. And all uncles, all uncles. So can we move to second OT?
Yeah, sure, sir. Thank you so much.
Yes, sir.
Thank you, Vidata. Congratulations.
Thank you, sir.
So next case is by Dr. Satyajit Sinha, sir. He'll be doing a live Phaco. He's a chairman of ABI Institute Patna and held many positions in our own society. And like Dr. Subhash sir mentioned, he doesn't need any introduction. Just to mention a few, he was the recipient of Dr. D.K. Bose Gold Medal Award for Best Scientific Paper at Bihar Ophthalmological Society Conference. He's a recipient of IRSI Gold Medal, ISCRS Young Achievers Award, and he has organized more than 100 CMEs in Bihar, and he's been constantly doing, and presently he is the Chief Scientific Committee of Chairman of Bihar Ophthalmological Society. So over to you, Dr. Satyajit sir. Can we have live images from the OR? And patient details.
Yeah, the patient is a 58-year male who presented with dimness of vision in left eye. Vision was 1 by finger count meters. K1 is 43.58 at 63 degrees. K2 is 43.90 at 153. Astigmatism is 0.31 at 51. Total K is minus 0.33 at 63. Axial length is 23.64 mm. We are going ahead with a Clarion lens of 21 diopters. The fellow eye is phakic.
So thank you for that kind introduction. I'm doing a case in which PSC is there. So I'm first making my cystotome. And I'm using this Luxor microscope for the first time. I'm more used to on my Lumera eye. So I'm, for a Rexis guidance, I'm putting a Rexis marker, which was invented by Dr. Ajay Paul. बीच में देखा जाए, बस light पे देखते रहिए, 5 मिनट में हो जाएगा. And now I am making a parasynthesis.
So timer has started for 5 minutes.
Your preferred size of capsular axis?
Okay. 5 millimeter, 5.5 millimeter. So now we have coated the endothelium, and then we have put HPMC. Is it centered over there?
Well centered.
Okay, thank you. So now I am going to make the main port, and just from the limbus we start, go right up till where the mark is, and this Alcon blades are very good. They're so sharp before you realize you are already in the anterior chamber. You want to fill viscoelastic once again. For more clarity, in between I keep putting viscoelastic on top of the cornea. ये दूसरा दीजिए तो 26 नंबर चाहे रेक्सिस फोर्सेप्स है तो वही दे दीजिए
You made only one side put.
Yes, I've made only one side put. Visco दीजिए So now I'm using that mark as a guide. I usually use cystatome, but since that one was not made properly, so to save time, I'm just
good capsulorrhexis.
So generally these kind of cataracts are very soft. So बीच में देखा जाए बस लाइट पे देखते रहिए 2 मिनट में हो जाएगा लाइट पे देखा जाए बस You want to remove a little viscoelastic from the anterior chamber before you do hydrodissection and बीच में देखिए बीच में देखते रहिए So you can see the whole flow from behind. So you want to do it once more from the other side.
So cannula you are using is perhaps 23 or something for hydrodissection?
23. Now it's important that you make sure that your nucleus is absolutely free, so you go ahead and rotate. Generally in these kind of cataracts it takes a little more effort to rotate these soft cataracts. So now it's freely mobile and we're going to go ahead with the phaco emulsification.
Clear separation of the nucleus from the. So he making sure to total rotation of the nucleus.
Sculpt.
Good crack.
So I am more used to their Infinity. This is a Centurion machine. So it's important that, like Ramamurthy said, sir earlier, that you should see the red glow right till the end, so that you make sure you have made a complete crack.
This is slight softer cataract. What is your OZIL in this case? Phaco power?
70% is there, but we will get it reduced.
70%?
That is not required. That's what they told me just now. So I'll get it reduced once I finish this. थोड़ा वैक्यूम भी कम कर दीजिएगा quadrant कर दीजिए This kind of soft cataracts, when you are making a trench to make divisions, sometimes there may be a possibility that you may hit the posterior capsule. So just to be on the safer side, if the whole quadrant, half of the quadrant is coming out, There's no point in trying to wait and make 4 quadrants.
Not in center. Good center. Thank you.
MBR. So now having completed that, now I'm not using any viscoelastic. I'm going to inflate the bag with the irrigation. And even इसको हटाइए नहीं, सामने आ रहा है, बीच में आ रहा है. बीच में देखा जाए, बस. बीच में देखते रहिए. Yeah, so now I'm making the paracentesis on the other side. ऊपर से विस्को डालिए. इसको उठाइए, नीचे लगेगा. इसको पकड़िए 1 मिनट. ऊपर से विस्को डालिए. बस बीच में देखते रहा जाए, बस 2 मिनट और में हो जाएगा. And now without using any viscoelastic, I am initiating the cortex removal. उसको cortex पे कर दिया है. So now I'm going to change hands and remove the remaining cortex. बीच में देखा जाए लाइट पे.
Good fast surgery.
More often than not, I recommend that these posterior capsule which you are seeing over here, it's a good idea not to rub the posterior capsule at this point of time. Once you have viscoelastic, once you have put the intraocular lens, then you can go and do the polishing. Different surgeons have different approach.
Can I say one thing about? At this stage, what I do that I use the fluid, actually the hydro polishing of the remnant of the few of the cortex which are there.
2.8.
You can just dislodge it with a jet of fluid, and many times we don't require actually just to So particularly when there is in the posterior capsule, so sometimes if you you have the temptation of polishing it with your instrument, it can have sometimes problems. So
polishing takes some more time. Even with the syringe, you just flush the fluid, you can clear these pieces, this tag.
So this is the order cert. So you click over here. It goes ahead by itself. You go up right to the end, and then at this point you should leave the trigger.
It's a preloaded Clarion.
Yes, Clarion. It's one of the most amazing lenses with a square edge, and it has the least glistening also, unlike earlier they had in IQ. So this is a wonderful lens that they have in their armamentarium now. बीच में लाइट पे देखते रहा जाए.
इसके बाद
बस लाइट पे देखते रहिए, हिलाना नहीं. And it's so controlled and smooth so that you're not even worried that there'll be sudden ejection of the IOL which may hurt the posterior capsule.
So that is the beauty of this preloaded autonomy lens. It goes so smoothly inside the bag. You never end up with any lens IOL misadventures like a stuck IOL or amputation. So that is the most important aspect.
One thing
of
also
this.
important, you can control the speed of the lens
Yes,
going
yes.
to the eye.
So wonderful surgery, Dr. Satyajit.
Wonderful surgery, Sajid.
Thank
Great.
you.
Take a clap.
Thank you for the opportunity, sir. Thank you for the opportunity.
Now we'll like to move ahead for the last presentation. I would say the last 10 minutes of the today's workshop, and it will be Dr. Sonali who will be presenting on contoura vision or topo guided LASIK laser. Dr. Sonali.
Dr. Sonali has recently finished her cornea and refractive fellowship from Sadhguru Net Chikitsalaya Chitrakoot and is a fellow of Moorfields Eye Hospital, London. She did a observership there and has recently joined Divyadrishti Eye Center as a full-time cornea and refractive consultant. And she has a very important talk. I would say it's a talk of the town, topo guided LASIK.
बीच में देखा जाए हो गया सब.
Is it worth? So I think all of us are very eager to listen to what are all the differences we have between LASIK, customized LASIK, wavefront optimized LASIK or wavefront guided LASIK, and the recent introduction by Alkan about contoura LASIK, which is nothing but a topo guided LASIK. So over to you, Dr. Sonali.
Thank you so much, sir.
बीच में देखा जाए लाइट पे बस लास्ट.
Hello. I'm sorry to be holding you for another 10-15 minutes. So I'm going to talk you about the topo guided LASIK and is it really worth the upgrade? So it's a very important topic, especially for beginners who have worked in different setup and different technologies. Coming to a new technology and new setup, it is another challenge to work with. So I do not have any financial interest. Briefly talking about how the refractive surgeries are evolved and what are the different patterns of surgeries that we have. So we have basically 3 divisions of refractive surgeries. One is the keratorefractive procedures, the other is lentillar-based surgeries, and the other is combination of the two. So the cornea-based surgeries have seen its evolution from RK to now the latest being SMILE. So it has had its own glorious evolution, but coming to LASIK, we had seen a different road of evolution of the refractive surgeries. It was in 1948 that Barker was the one who discovered the microkeratome and he used it to reshape the cornea. In 1974, Fyodorov was the one who did the radial keratectomy to treat the corneal, to flatten the cornea. In 1987, Theo Seller was the one who did his first PRK, and in 1989 was when the first laser ablation was done under the flap. But it was just in 1999 that LASIK got the FDA approval. So what are the evolutions in laser visual correction? So we have had options for plano scan, wavefront guided came into picture, then we had another advancement, wavefront optimized, and now the latest being the topo guided treatment. So what is different from the standard laser treatments and the now latest advanced topographic treatment? So the standard laser treatment, it used to eliminate the conventional refractive errors, but at the same time also induce higher order aberration as a result of the ablation process. So the pre-existing higher order aberration could be exacerbated by LASIK itself as well as multiple other factors like dehydration of the cornea and decenteration. So the mechanism of increase in the higher order or the lower order aberrations during the ablation process was because of the irregular astigmatism cause or an oblate shape of the cornea, decentration, small optic zone, a large pupil. So these would contribute into vertical or horizontal comas, spherical aberrations and trefoils, which would then cause artifacts like glare, starburst, halos. The higher order aberration can cancel out or modify or induce the lower order aberration as well. But higher order aberrations being the maximum to affect the visual quality is a trefoil. So to combat these side effects or the disadvantages of the treatment, the wavefront guided ablation was created. It was designed, it was based on the aberrometry, designed to correct the lower order aberrations and also reduce the higher order aberrations. It would consider the aberrations of the whole of the eye, but treat at the cornea level. It also did not correct the aberrations created during the process of the treatment. Another limitation of the surgery was that the peripheral cornea was not treated, and it would vary with pupil size, location, accommodative status of the patient. It was centered on the pupil aperture and also would ablate more tissue. So, to cover up the limitations of the wavefront guided ablation came the wavefront optimized treatment. So, in this, they made the laser pattern customized treatment based on the unique keratometry and refraction of the patient cornea. It would minimize the spherical aberration by adding pulses also in the periphery. In the diagram where we can see this is the correction given by the wavefront optimized, where there is a peripheral correction also. If we do not provide a peripheral correction, you can see that the sphericity of the cornea is hampered. So with the help of the wavefront optimized, we would actually preserve the sphericity of the cornea also, but the limitation being it does not correct the pre-existing aberrations. So another advancement came into the laser field, that is the topo-guided treatment. This treatment was introduced in 2003. It would customize ablation profile based on the topographical examination. It was based on a software, the TCAT software, which would regularize the irregular corneas, giving us the brightest vision. So what is the disadvantages of wavefront guided or the advantages of topo-guided treatment over that? So the wavefront guided treatment, as I said, it would consider the higher order aberration of the whole eye, that is including the lens. And as we know, the lens changes with age and it has a different refractive index also. So doing a treatment based on the whole of the eye and treating it on the corneal plane will not give us the brightest vision. Because the 70% of the refractive errors are from the cornea, topo-guided treats only on the cornea, taking the data from the cornea itself. That's why it has a better advantage over wavefront guided. It is also static, whereas the wavefront guided is dependent upon your accommodation. The topo-guided treatment is accurate and more reproducible, independent of the pupil size. It is quick and relatively easier to acquire with topographical images, able to produce better peripheral data, and highly reliable for higher order aberrations. It is also does not, rather than working on the center of the pupil, it works on the corneal apex. So what is contour vision and why are we talking about contour vision and why has it gained so much of power in today's area? So contour vision is nothing but a topo-guided treatment. It removes your spectacles, corrects the corneal irregularities and acting on the visual axis, giving you the sharpest vision that is beyond LASIK and SMILE. It gives you a personalized treatment, just like your fingerprints that are personalized to you, your eye treatment are personalized to your eyes, which is completely unique and better than any other treatment. So the principle behind the contoura LASIK or the topo-guided LASIK, there is theorized to be a link between the higher order aberration removal and the astigmatic correction. So the contoura, what it does, it analyzes this link between the two things. So any presence of coma, trefoil or other aberrations can cause astigmatism, as we have learned in the previous slides. These astigmatism cut to or cancel out or lower other astigmatism depending upon the relationship to the pupil. The contour software calculates this linkage using the LYRA software. LYRA is the layer yoke reduction of the astigmatism. This software, it provides the link and provides a measurement of the astigmatism and axis, and the reading is dramatically different from the manifest refraction. So how we perform the contoura LASIK is we take the data of the wavefront with the help of wavefront topolizer Vario. The data is then used in the TCAT software where we combine the data along with the clinical refraction, and then we give a customized laser according to a person's eye. So the standard lasers, some of them would use 2000, the wavefront optimized would use 1000 scans, but the contour vision, it uses 22,000 vision maps. That is why it is able to provide the sharpest and the brightest vision. And that is the reason why 98.4% would say that they would go for the procedure again, and they would recommend also to their known and relatives. It is not just a perfect vision, but a magical vision because of the topolizer using 22,000 unique data points. The treatment, again, like I said, another treatment modalities like the normal LASIK or the SMILE is based on the pupillary axis, which is a line passing to the center of the eye. Whereas the contoura LASIK is based on the visual axis, which is a line passing through the line of the sight. And the difference between the two is 5 degrees. The reason, again, being more accurate in providing the vision and a sharper vision compared to other modalities. This is a short example by which I want to highlight. So the the one in the left side is a wavefront optimized ablation profile given for a patient who was 20-year-old refractive power of -1.75. That's the ablation profile given for a patient. And the one in the lower, we can see This is the ablation profile of the higher order aberration only. So this is only picked up by the TCAT software in the contoura LASIK. This is the amount of higher order aberration which would be missed otherwise. So the contoura LASIK, or the software, what it does, it combines the two images, combines the two profile, and creates a midway profile to treat both the refractive power correction as well the higher order aberration. So as we all know that if it has had very good results in spherical aberrations, but it also has a promising result in astigmatic correction. This was one of our patients who had -3 diopter cylinder at 180 degree, and vision was, best corrected vision with glasses was 6.9. But post contoura, the patient was able to achieve a 6.5 vision, which is a magical in today's world. This is the same scan of the same patient who had -3 diopter astigmatism. We can see this is a higher order aberration that was present in the patient, and the one in the right is the ablation profile of the patient. And in this scan, this slide, we can see the higher order aberration pre-contoura and post-contoura. That's the significant amount of difference that contoura creates. Not just this, we also have FDA approved trials that has led to this advancement of the contoura and being accepted at so many places. It was a prospective observational study with 249 eyes having the data, -9 sphere with -6 cylinder. The patients at 12 months, the UCVA in 93% patient had more than 20/20 vision, and 65 had more than 20/16. That's 6.5. It is the better vision that, it is the sharpest and the supervision that the patient had after 12 months. So 92.6 had 6.6 vision at 12 months, and 64.8 had above 6.6 vision. And at the end of 12 months, the post-op UCVA compared to the pre-op BCVA, 30.9% said that they had a better vision. Again, 40.4% gained vision more than one line. These are some of the other advancements that the contoura had. There was decreased light sensitivity in these patients. Difficulty in night driving was reduced, reading difficulty was reduced, complaints of glare, starburst, halos all showed reduced. That's why 30.9% patients outperformed glasses with the help of contoura vision. Another comparison of LASIK versus SMILE, SMILE is nowadays the most go-to surgeries and the most advanced surgeries, yet it does not correct any higher order aberrations. So this was one of the study conducted in 2017, and contoura was FDA approved in 2016. So it was compared to SMILE in 2017 in this study, and they concluded that topo-guided LASIK was superior in all vision performance parameter studies, both subjective and objective. And the main difference between the two techniques are because of the eye tracking, cyclotorsion compensation, and the centration control. And these were the reasons for the difference that affected the refraction and the visual aberrations outcomes. Again, the FDA results for both the things. SMILE, for the SMILE, FDA approved it for astigmatism for 0.5 diopter only, whereas for contoura, the FDA approved it for 3 diopters, which was 6 times. This itself is a summary of how confident they were for the SMILE to treat astigmatism in patients. The vision recovery also in contoura was instantaneous, and SMILE would have haze for a longer time. 6.6 vision was achieved in 92% of the patient, whereas only in 88% of the SMILE, and the supervision or the better vision was not even commented in SMILE surgeries. This is another slide just differentiating topo-guided with another wavefront optimized, and both showed to have excellent result, but the topo-guided had better contrast, lower inductions of higher order, and smaller amount of tissue ablation. Just to conclude my side, we have had milestones at DDEC where we inaugurated the EX500 LASIK in 2013, and it was in 2017 that we inaugurated our contoura LASIK. We were the second in eastern part of India to have this machine, and it's a privilege for us to have treated so many patients with 461 laser procedures done, out of which we have treated 3,642 with contoura LASIK, and 98% have had 6.6 vision, and supervision have been seen in rest of the patients. This is the data that all the patients that we have had. Summarizing, LASIK is commonly performed, contoura vision gives you the brightest treatment, and if you want the supervision, then topo-guided LASIK or the contoura LASIK is your answer. Thank you so much.
Thank you, Sonali, for a good presentation. One thing I want to know, okay, how much astigmatism up to which power you can go for this, and
So
with good outcome?
So the FDA has approved for a spherical equivalence of -9, And for the astigmatism correction, they'd gone for -6. So what we have corrected is up till -10, and then we have had good results, sir.
Okay, thank you.
Thank you, sir.
Thank you, Sonali. It was a very nice presentation, and you covered all the technical aspects and outcome very thoroughly. So, yes, it's true that we have started from wavefront guided to optimize, and now in the ages of topo guided refractive surgeries. And definitely it has a lot of potential benefit to the patients when we are treating the spherical aberration. But there are a few concerns, like how often do you choose the patients offering topo-guided refractive surgeries over others? And what are the parameters do you keep into account that these patients will absolutely need topo-guided treatment only and we can't go for any other modality?
Ma'am, so we do check the patients on topolizer. If we see the higher order aberration is too much, definitely we do advise the patients to go for a contour LASIK. But if the patient does not have any significant amount of higher order aberration, he can go well ahead with a normal LASIK laser as well. And another thing, the ideal patients for a LASIK are the same. The keratometric reading should be same, the power should be stable since last 6 months, and he should not have had history of contact lens at the time of investigations, at least for 4 weeks. So the ideal cases are the same like in other cases, but yes, the higher order aberration, if the patient is complaining about starburst or comas, those are the concerned patients, and also their occupation. If they do complain of starburst or halos during night driving, those patients are the one we need to be concerned about. And also, if we do not have a ray tracking system, we can also have the aberrometer to screen out or rule out those kind of patients.
There is one concern in topo-guided that sometimes, because aberration is not because of the corneal tissue only, it may be because of lenticular aberration.
Yes.
So once we correct the corneal aberration completely, in that case we can unmask the lenticular aberration.
Yes,
Did you feel this happened in your cases, in any of the cases?
Not yet, ma'am, not yet, because those patients were very wisely planned, and if they did show any lenticular changes, they were not opted for such surgeries.
Yeah.
Thank you, sir.
Just to answer your question, Dr. Raki, new technology is coming with Alcan for CDs, which will also consider lens aberrations, the aberrations from the lens, while correcting along with correction of topo-guided LASIK.
Suppose the patient has thinner cornea, but he has no evidence of keratoconus. Now, what modality would you choose? Topo-guided to eliminate the corneal aberration also, or optimized?
Would you like to answer, Sonali?
Yes, ma'am. I would like to go for ahead with the contour LASIK in this patient.
In cases of thinner cornea without any evidence of keratoconus. And PAR could be anything like more than 4 with this spherical aberration. Not much aberration, but yes.
So that's a trick question.
Epi contoura is the answer to that. We can, in cases of thinner cornea, we can go for an epi contoura.
Yes.
Yeah, so obviously our preference will be surface ablation, but I would still prefer to do wavefront optimized because it's a tissue saving procedure compared to the topo guided, which takes more tissue into account compared to the wavefront optimized surface ablation.
So there are some
but obviously surface ablation is the, I mean, we'll all do epi contour.
Yeah, regarding Raki's question, the thinner cornea depends how much power the patient has and how much thin the cornea is, and what the pupil size and everything has to be taken into account. And the most important is the topography of the patient, whether there is any evidence of keratoconus, earlier keratoconus or not. If it is not, it is there, then even with the thinner cornea, we can go ahead with the surface ablation, but one should not go much beyond, we should not treat if it is less than 450 or 460 or so. And maximum correction I can do is the 3 diopter or so. So many times we get persons or I won't say patient, persons with they want spectacle remover for the job. In those situations we can go ahead with the surface ablation even if the cornea is not 490, but other parameters are quite good. So in those situations, and if you decrease the optic zone size, suppose the pupil size is not going beyond 6 millimeter in scotopic or mesopic, then we can just reduce the optic zone size so that we can save more tissue in those situations also.
Thank you, sir.
Thank you.
That was a great talk, Sonali.
Thank you, sir. Thank you,
And
ma'am.
I just wanted this talk to be here because we know that Bihar, there are a lot of patients of spectacles wearing. I actually should not call patients them. They are normal person, but they are using spectacles. They want to get rid of glass. And in Bihar, we have ample machines now, ample number of good surgeons like Dr. Aziz is there, Sonali, myself, and there are a lot of machines, but still all Bihari patients are going out. And just to compare, nearby our just adjacent state, Kolkata has 4 EX or 4 contoura, Patna has 5 contoura machines.
Still patients are going out.
And
And
one
there
more
are
machine there.
so many keratoconus patients, mild to moderate, and they require actually this kind of treatment with C3R or without C3R.
So many things depend upon the media, and if you are falling in going to contact with the media, then certainly the cases will go somewhere else, and you should manage for that. Thank you.
So with this, we come to the end of this workshop, and I'm so thankful to all of you for coming and actually gracing this occasion, and at the same time taking back with some tips, practical tips. I know all of you are good ophthalmologists, all of you are doing lot of good phaco and many other things, but it's always that whenever you see any surgery, you certainly listen, certainly get some new tips from everyone. And today's session was actually has shown us how to manage the complications, how you handle the situations, and how you can be so efficient a cataract surgeon even if you are slow and meticulous. So thank you so much, everyone. And this was a great occasion for all of us, particularly for Divyadrishti Eye Center, because 2 new ophthalmologists has joined us, Dr. Sonali and Dr. Vidhata. Dr. Sonali, she is my daughter also, Dr. Vidhata's son-in-law. And 2 live surgery which was done from our OT. That was first time the surgeon who has performed. Dr. Bholes, this was his first live surgery, and he has done it wonderfully, was so confident. And Dr. Vidhata, first live surgery. I know the difficulty in performing before audience, operating in OT is different stories altogether, but coming live in audience when you have a lot of experts, particularly those coming from outside, they are watching you, then it becomes very difficult. So hats off to you 2 new guys for performing so well. And thank you so much. I just want to hear 1 or 2 words from respected sir, A.K. Grover sir. How do you feel about this work? So I'm so thankful to you, sir.
So I was in any case going to take mic from you to say 3 cheers to Subhash and the Divyadrishti team and all of you on a Sunday, so many people gathering here, and for the wonderful organization of the live event, such a wonderful transmission, and very good scientific content. So I think it's been a wonderful workshop, really good experience to be here, and most of all for giving me the opportunity to be in Patna again. Thank you so much, beautifully organized, and thank you all for being so scientifically participative. Thank you.
If someone wants to come for photograph,
we'll all like
can
to.
you join if somebody want? Yeah. Sir, ऊपर में ये लाइट ऑफ कर दीजिएगा पीछे, ये पीछे डिस्प्ले. हाँ सर के साथ लेना है. आइए सब आइए, आप भी आइए, विनोद जी आइए, सब आइए. यहाँ का लाइट ऑन, यहाँ का लाइट. कुछ लोग सर हम लोग पीछे, आप सर ऊपर आ जाएंगे सर. आप लोग पीछे खड़े हो जाएंगे. आइए.
सब लोग आ गए ना, स्माइल करने को तो बोल दो।
और भी जो लोग हैं दिव्यदृष्टि के, कोई आना चाहे आइए, या आप तो भी आइए बाद में, यू कैन हैव योर लंच बाद में। अंशुमन अंशुमन कहाँ है भाई? ये तो भाई यही सब चुप जाते हो, यही बात गड़बड़ है। तो तुम्हारे पापा तो फोटो खिंचाने में सबसे आगे, तुम सबसे पीछे। नहीं सर, इधर जाता है कि जाएंगे कितना आदमी को पैर छुआएंगे, कमर दुख जाएगा।
Thank you again.
जो बच गए हैं, खाना नहीं खा पाए हैं, प्लीज लंच लें। राजेश जी, थैंक यू सर आने के लिए। खाना खा लीजिए सर। डॉक्टर रुंगटा, एज यूजुअल, ही वाज द फर्स्ट पर्सन हु एंटर्ड दिस हॉल। अच्छा।